Hi everyone. So here is what we shall be doing today. It's a pathology class, as all of you know, and I hope you have viewed the previous 2.5 hour lecture where we had discussed the first part of the chapter cell injury. As I had told you in the previous class also, cell injury will be covered in a total of 3 classes in the decreasing order of their timing. That is, the first class covered your basics of cell injury, reversible. I hope before I begin, I hope you've gone through that class. You've revised it. It was just a single class which I believe was not too heavy on your brain and was not something that I asked for too much of revision. So I believe it was pretty much doable. We have done the cell injuries, then in the cell deaths, we have gone through necrosis, and we have almost covered apoptosis also. Today, of course, we will be doing all the other cell deaths. That is what is planned. So we will continue with the cell death in today's class. And along with that, we will also start with the topic known as adaptations. We will finish adaptations also, in fact. All those terms you heard of, hypertrophy, hyperplasia and all of that. So all of that also will be done. And then the third class which will come up on cell injury, which will of course be later. And I hope all of you remember that going Jan onwards, we will have more number of classes. Obviously, November, December was to give you a hang of what is going to happen, to actually make you familiar with the concept of live classes. January onwards, for Path, Micro and Pharma, you will be having almost 3 classes a week. So you will, and that is also not much, because for 3 subjects you can have 3 classes a week. I mean, if you look at it from subject point of view, it is again doable, and that is when we will go in a momentum and we will have monthly targets to finish. So let's put our hand on our heart and tell me honestly, because I've told you the first rule of these live classes was not to be scared of the teacher who is teaching you. Because if you're scared of all of us are, I've been in your place, and we're very scared to ask our doubts. But if you're scared, your doubts will remain unsolved forever. So let's keep our hand on our heart and tell me, did you genuinely revise the first part of cell injury which I taught you? And I'll be okay, I'll be very happy with the yes, but I'll be okay with the no also, because I understand you're just getting on with the entire curriculum. It is okay if you haven't, because you have a backlog of only one class in that situation. So every time that you will come for a new class with me, you will have to be very honest about what you've done of the previous classes, and very honestly you will have to tell me whether you've done the revision or whether you haven't. So what is your take on it, guys? Have you all revised, and have you gone through the lecture even once, even if it was a few days prior? Okay, you've done that, very good. But Dr. Om, yes, a lot of topics would have been left because we have not covered cell injury, right? Abhi to we have not even done 1/3 of the topic or 1/3 of the chapter. So how can we actually cover the entire thing? It is not covered. So you will be able to find completion of the chapter when all the 3 lectures are done. Okay, so yes, I can see yes from everyone, so I'm very happy on that. Let's get going. Today we'll be going on, and we'll be starting off with where we left. So let me ask you a basic question since you've revised. Apoptosis. What was that last point of apoptosis that I taught you, where apoptosis means what? This is just a revision from the previous class. Apoptosis is a Greek word, means falling off. Do you remember there was one big cell and then it was falling into certain tiny pieces? Because that, whatever I taught you was very bookish knowledge, what Robbins and what textbooks mention. Today what we'll study is going to be the knowledge which you will get as a pathologist, as a practicing doctor, that okay, all this I have read is happening in my body, but if I have to do some test, if you ask me, ma'am, can you as a pathologist do a test and tell me, is apoptosis going on in my body right now sitting over here? Am I having apoptosis? That is exactly what we are starting with. Very good. Caspase dependent programmed cell death. Yes, that was apoptosis. So now let's start with the job of a doctor. Okay, the actual work. Like if you ask me, what are the tests that I will do? I believe everyone knows that my weapon for everything is a microscope, right? That is what I'm surviving on. That is what pathology is all about. And Dr. Om, we'll take up all the doubts, but kya karte hain, abhi with a fresh mind na, let us finish off today's class, whatever topics we've decided, and after that we have all the time. Okay, so we will sit and do all the doubts that you have. So yes, microscopic examination. You'll say, first thing, ma'am, if you take a biopsy from our body, you will look at it under the microscope. So how does apoptosis look like? And these are the 2 microscopes. You guys know it. When I say pink and blue microscope, it's the light microscope that all of you have in your pathology labs. When we say black and white microscope, which microscope is it? This I taught you in the last class. Black and white photo aaya. This means the microscope is an electron microscope, which many of you will not be having in your hospitals. That is fine. because it's a very, very expensive microscope and very limited centers have it. But light microscope is going to be there in every medical college. So when you want to see, I'm not telling you what organ is it, doesn't matter whether it is skin or whether it is brain or whether it is heart or kidney, apoptosis can happen everywhere. So can you see there is one cell which is, I'm just labeling, this is a normal cell, and then can you see one different kind of a cell over here? This is an apoptotic cell. All of you will give me the description. There are 3 points of apoptotic cell. I will not give you the description because then you will listen to me and you will forget. This is an apoptotic cell. Compare the size. Number 1 size, number 2 pink color and blue color. That is what is pathology. Size, pink, blue. So tell me, if this is a normal cell, what has happened to an apoptotic cell? Ma'am, the size has become smaller. So number 1, can I say there is going to be cellular shrinkage? Do you agree with me on that? Yes, there is cellular shrinkage, because now this is a question which, usually Viva doesn't go on these topics. These are very theory topics. No one will ask you in practicals. But when does Viva come to this place in practicals? In 2 situations. One, either you are a very, very intelligent student, that is, you have answered everything in your Viva exam, and then the examiner is thinking, what more should I ask him or her so that I can cut his marks? That is when he will start asking you this. He will get into theory too much. Second, if you don't answer anything at all, then examiner will ask you, what have you studied? Tell me one topic so that I can pass you. That is when you can say, I have studied apoptosis. Only 2 times when your Viva comes down to this. Otherwise, no one asks you apoptosis in Viva exams. They are very theory oriented topics. So examiner will ask you, Acha, tell me, in apoptosis, what happens to the size of the cell? And you will say cellular shrinkage. But if I ask you as a Viva examiner, what is the first change of cell injury? Remember that water balloon photo of the previous class? Whenever cell injury happens, the size of the cell is going to become big. Remember, cellular swelling happens, water goes inside the cell, cellular swelling happens. So can I say in all other cell deaths, like if I ask you in necrosis or if I ask you in apoptosis, in all other there is going very good, hydropic change, all of you are right. In all other, the cell becomes big. It is going to be like a water balloon, but in apoptosis, I can see the cell is becoming smaller, and that is common sense. It's nothing which is to be mugged up. I just told you apoptosis was a big cell was breaking into small bodies. So obviously one big cell, if it breaks into parts, those parts will be smaller only. Na? So the cell has undergone a shrinkage. Now tell me the color. Compare, guys. Compare the color of cytoplasm. The normal pink color and compare the pink color. I think in a apoptotic cell it is looking very, very pink. I can zoom in also and show you. Now compare. This is light pink and this is going to be dark pink. Boys are really going to hate all this because they don't understand shades. Now for boys it is just pink. Girls will love it. If I say, oh, this is baby pink and this is magenta pink, girls are going to love this, but boys don't understand. So let's include all the boys also in our discussion, and let's keep things like light pink and dark pink. These are the kind of colors that we will use. Okay, so I am saying it's becoming very, very pink. Can I say dense is what it has become? So I will call it dense pink. Let's not talk like layman people. Let's talk like pathologists. What is pink known as? Pink is known as eosinophilic. It has become dense eosinophilic in color. Now I want you to compare the nucleus. Once again, I will zoom in. You will tell me, guys, look at the nucleus of a normal cell and then look at the nucleus of an apoptotic cell. Size mein I can see it has become smaller. Understood. But what is the color? Can I say this was a little lighter? Again, I'm using light and dark for all the boys. This is a little light blue, but over here it has become very, very dark blue, very, very condensed and dense. Yes. So what happens? Understand, then I'll write. Look at the nucleus in a normal cell and what is inside the nucleus. If this blue color is the nucleus, I can see that this blue material over here is known as nuclear chromatin. This is what every normal nucleus has, nuclear chromatin. So it is, it has space. It's a big nucleus. The chromatin has space. Some chromatin is sitting here, some is sitting here, some is sitting here. It is chilling. It has a lot of space to sit. But once the space crunch happens, the size of the nucleus becomes smaller. All that chromatin now has to fit inside. So don't you think it will become condensed? And that is what happens. The nucleus that I can see over here, you are right, it becomes deeply basophilic, but that's not how we describe. When I say nucleus is becoming dark blue, in pathology we say it is becoming hyperchromatic. What do I mean by that? Hyper means more, Chroma means color. It has become more blue in color. So hyperchromasia. Why has that happened? That has happened because of new NCC, nuclear chromatin condensation. Let us write it. What is the hallmark of apoptosis? If you are asked in the exam, and this you will have to write in your theory exams also. What is the hallmark of apoptosis? It is this nucleus, which is, everyone's understood what is the nuclear chromatin. Nuclear chromatin is all the material inside the nucleus, and it has become very condensed. This is the hallmark of apoptosis. Now everyone will tell me that, ma'am, whenever someone comes to you to the path lab and wants to find out apoptosis, what do you see under the microscope? I'm going to write 3 points. You guys fill in the blanks. What happens to the size of the cell? The size of the cell becomes smaller. What happens to the cytoplasm of the cell? Everything becomes more in color. The cytoplasm becomes more pink. And what happens to the nucleus? The nucleus becomes more blue. So overall, I understood size becomes small, but the colors become more. Pink is more, blue is more. But now I want to ask you, now the point of studying in detail is that you should know every little point. Now, even if it is for INI exam, AIMS, JIPMER, any other central institute also, you should be able to answer. So if I ask you hallmark of apoptosis, you said nuclear chromatin condensation. But if I say what is the hallmark of neuronal apoptosis, and what is the difference between apoptosis everywhere in the body but apoptosis in the brain or the neurons? Now the problem is, like Dr. Om, the first question answer you mentioned to me was, ma'am, apoptosis is caspase dependent programmed cell death. That is what you wrote in the chat box. So you need caspases. If you want apoptosis to occur, you need caspases. The problem is that neurons don't have normally God has not given any caspase to neurons. There are no caspases present in the neurons. Now tell me, how will apoptosis occur there where there is no caspase? See, God has a simple universal fact, which is a life lesson for all of you. If he will not give you something, if he will deprive you of something, then he will compensate by giving you something else in life. Same way, over here, God deprived neurons and said, I will not give you caspases. Then God must have given it something else to carry out apoptosis. So the hallmark of neuronal apoptosis then becomes AIF. Instead of caspase, God has given it apoptosis inducing factor. Is that okay with everyone? Yes. So you can say, ma'am, both of them are going to do the same thing. Caspase also carries out apoptosis. Apoptosis inducing factor will also carry out apoptosis, but it's what God wanted to give. To all cells of my body, God gave caspase. To neurons, God said, I'm not giving you caspase. I'm going to give you apoptosis inducing factor, which is written as AIF. Okay with everyone? Can I go back and find out other methods? Now you will say, tell me other questions. What is the marker of apoptosis? And that is going to be annexin 5. Now, what is this, ma'am? Does someone come to you in the pathology lab saying, okay, please do my annexin 5 testing? No, no one comes to me. I mean, non-medico doesn't even know. Some doctors also don't even know annexin 5 exists. How do I know that I have to do annexin 5 testing? So if I see this kind of a photo and I realize that I think this is an apoptotic body, because whatever ma'am had written, size small, pink, blue, all that is looking, but I'm not very confident. So now for my confidence, what can I do? For my confidence, I can start putting some markers. Markers are nothing but stains. You know, pathology, all of you study, you got those two pencils in second year, na? Pink and blue, hematoxylin and eosin, because undergrad level only that much is required. But as a pathologist, I sit inside an entire rainbow in a lab, okay? I deal with pink, blue, green, yellow, golden, black, all sorts of color stains. And annexin 5 is one of the stains that I can put. But now you will ask me that, ma'am, last class 40 minutes you taught us apoptosis. Did I mention annexin 5 anywhere? I did not. But today, when I'm saying what is the marker of apoptosis, I'm saying annexin 5. You might feel a little, you might feel ma'am has taught us incomplete last time. So ma'am did not mention annexin 5. Today she's saying that's the marker of this entire cell death. But I taught you something else. What did I teach you? Do you remember a concept called flipping of phosphatidylserine? Do you remember this? That normally phosphatidylserine is present inside the cells, and in apoptosis the phosphatidylserine comes outside the cells. Do you remember this flipping of phosphatidylserine? That is happening inside my body, na? That normally PS is inside the cells, but in apoptosis it will come outside the cell. It is happening in my body. How does a pathologist sitting in a lab 20 kilometers away from me know if I will give my blood sample, or if I will give my some tissue sample to that pathologist. What test will the pathologist put? Pathologist will put annexin 5. What does annexin 5 test? Annexin 5 tests the flipping of phosphatidylserine. So this means annexin 5 will go and bind to which molecule? It will bind to phosphatidylserine. So let's assume you have two people. Let me see the two people who've recently commented, Om and Umar. Okay, I'll take you two as examples. Let's assume, and apoptosis is a very normal thing to occur. It can happen in anyone's body. It's physiological also, right? So let's assume that Dr. Om is right now not having any apoptosis in his body, and Dr. Umar is having apoptosis in his body. And both of them decided they will give me their sample. So I put some colorful stain on their sample, annexin 5. Dr. Om's sample came out to be annexin 5 negative. This means his sample was not showing me phosphatidylserine. So are his cells currently showing apoptosis? They are not showing apoptosis. The same stain when I put on Dr. Umar's sample, then that came out to be positive. This means his cells were showing me phosphatidylserine. This means Dr. Umar is currently having apoptosis. And does that mean does he have a disease? Touch wood, he doesn't, because apoptosis is a very normal thing that can happen in anyone's body. Now, if marker is asked, your answer is annexin 5. But if molecular marker is asked, your answer will be CD95. What was the other name of CD95 that I taught you in the last class? CD95 is fast. And now, ma'am, what is the difference between a marker and a molecular marker? Whenever in pathology the word molecular comes, molecular anything, molecular studies, molecular marker, we are dealing with something known as CD markers. Okay, so whenever I say marker, you will say annexin 5. When I say molecular marker, you will say CD95. Before I move forward, I just want to ask you something. You know, I'm teaching you, I'm not saying कि अभी cell injury है तो only cell injury you will study. Anything I feel that can correlate with any other chapter, I will teach you right now so that your correlation and integration happens. So when I say apoptosis, what is the annexin marker that you want to write? Annexin 5. How do we learn it? Because apoptosis has A for annexin and P for penta or panch, however you want to learn it. So you will say, okay, annexin penta is the marker of apoptosis, because the next MCQ that you will get, what is annexin A1 a marker of? See, the alphabet and number has changed, and that is a marker of a blood disorder called hairy cell leukemia. How do we learn it? See, hairy cell has AI in it. So for annexin A1, I can say hairy cell leukemia, and apoptosis has A penta in it, so I can easily say annexin 5. Are we okay with the two markers? You will never mess up between these two annexins. In all 19 subjects, there is no more annexin that you will be asked. This is the only annexin that they are going to ask you. Ab thoda, let us move forward. Where have I reached? I have done marker, molecular marker, microscopic examination. Still, ma'am, the stains are not over. I told you, I sit inside a rainbow, right? I have so many colors in pathology. One more stain, and the name of that stain is a very interesting one. That is known as the tunnel stain. So you will say, okay, now you can do one more stain called tunnel stain. How many of you want to know the full form of tunnel? Tunnel is not that tunnel on the roads and everywhere. No, not that tunnel. Okay, tunnel is a short form. And now I will tell you the full form. It is TDT, DUDP, NIC, and labeling. Every time I tell the full form of this, students are like, it's okay, ma'am, we are okay with not knowing the full form, we are okay with the short form. But you have to understand, it's not that you are just mugging up. Why am I using, see, T for TDT, U for UDP, NEL for NIC and labeling. NIC and labeling. What am I trying to tell over here? So what am I studying with? Apoptosis, matlab the nucleus is breaking. Is the nucleus made up of things like UDP, UTP? Is it made up of all those nucleotides like A, T, C, G? That is what I am trying to test. I am trying to test the nucleotides. So tunnel stain, if it comes out to be positive, that will always tell me that what is going on in the body? Apoptosis is going on in the body. But if tunnel stain comes out to be negative, it will tell me that necrosis is going on in the body. It's very easy to learn. Tell me, apoptosis, I ended up writing it apoptosive because it was, I'm talking about positive, right? Apoptosis is going to show you what tunnel stain? It will show me positive tunnel stain. And necrosis will show me what tunnel stain? Negative tunnel stain. Will you be able? So these are some buzzwords I keep telling you that even if you don't revise, now you will if you ever get confused, you will remember that yeah, in class ma'am was writing positive, apoptosis is positive and necrosis is going to be negative. Okay, 4 things. How to identify as a doctor, ma'am? You have told us 4 tests, not 4, 5. I will tell you now the 5th and the last test, and that is DNA gel electrophoresis. Very interesting test. Whenever I say electrophoresis, go back to your chemistry days. Do you remember cathode, anode, positive end, negative end? Do you remember all of that? Yes. And we can do that positive, negative for anything. If you want to say, ma'am, can I put my hemoglobin sample inside electrophoresis machine? Yes, you can, because you have so many hemoglobins, you can separate them. If you say, can I put my protein sample, like my blood sample, will you tell me how much of protein do I have, how much of albumin I have, how much of globulin I have? Yes, anything you want to separate, use electrophoresis. You want to separate hemoglobin, use this. You want to separate proteins, use this. All that you have to do, put a blood sample and the machine will do everything else. Here I'm not interested for all of that. Here I want to look at DNA, because here my main purpose is to be able to differentiate between apoptosis and necrosis. So now we have 3 people who have come up over here. Okay, so 3 people over here. Now I will talk about, let's see, the person, let's name them ABC for our ease. Okay, so what have I put? I have put all 3 people. I took their little bit of blood sample and I put that whatever DNA I got from their blood sample, I put person A's DNA over here, B over here and C over here. So I will label their DNA with this red color, person A, person B and person C. Then I did that same cathode, anode, positive, negative, because electrophoresis, I saw in person's one's DNA, it remained this much. Ma'am, it remained intact. Can I say in person A, the DNA is going to be intact? Which means, does he have necrosis? No. Does he have apoptosis? No. He is a completely normal human being. There is no necrosis, there is no apoptosis. Normal person like you and me sitting here studying, fine. Now let's look at the DNA of person B and C. I saw their DNA has broken and gone all the way till the end. Their DNA parts have broken and they have gone all the way till the end. Something is going on in them, necrosis or apoptosis. So let's see, what is this? Their DNA is broken in what way? Can you see? Is it broken in the form of these steps? So what is person B having? This is the famous step ladder pattern. Okay with everyone? Any confusion? Do you think you won't be able to identify in the exam? MCQ आया, you will be able to identify. If you have to write a theory paper, then you will make this on your own. That's why I've got you this diagram over here. You will make this and you will show the examiner that steps are being made. Step ladder pattern. So you will now answer, why is the step ladder pattern coming? Because I have already taught you in the last class. It is now to test whether you have revised. The DNA could have broken in big part, then small part, then small part, then small part. DNA has not broken like that. DNA decided, I will break in equal steps like this. Why is the DNA breaking in equal steps like this? Very good. Like Dr. Umar says, internucleosomal cleavage. Do you remember in last class I told you that the DNA always breaks after 180 base pairs? So it says, excellent, everyone remembers, 180 cut, 180 cut, 180 cut. After every 180 base pairs, it says cut. So these steps that are coming are made up of how many base pairs? They are made up of 180 base pairs, exactly. So this is why step ladder pattern is formed. So when someone asks you that step ladder pattern is seen in which cell death, obviously it is seen in apoptosis, but can it sometimes also be seen in necrosis? Answer is yes. So now if you have to write your theory, this is how you're writing it. But if an MCQ comes, step ladder is seen in apoptosis, necrosis, both, your answer is both. But if you don't have both and you have to select one answer, then your answer is going to be apoptosis. Let's go to patient C. I saw his DNA is also broken till the end, parts are going, but his DNA is going in a very different manner. I can see it's going like, imagine you took a drop of ink, pen ka ink you took, and then with your finger you have smudged that ink. Someone has smudged it. So this pattern is referred to as the smearing pattern. This pattern is smearing pattern, and smearing is seen in what? This is seen more commonly in necrosis, but can it sometimes be seen in apoptosis also. Yes. So now life becomes easy. Very easy. If the DNA is intact, chota, it's a normal person. If the DNA is broken into steps, then also this can be seen in both the cell deaths. If the DNA is broken into smearing, then also it can be seen in both the cell deaths. The more common one I have to remember, step ladder is more commonly seen in apoptosis and smearing is more commonly seen in case of necrosis. Are we okay with this? The 5 techniques are done, because now you are going to do all the revision for me. Now this I've got as a test to see what I have taught you. Were you listening? And what I taught you last class, did you revise? You will fill in the blanks for everything to do with apoptosis. Tell me what kind of a cell death. This answer to you had given me that, ma'am, it is a caspase dependent programmed cell death. Does apoptosis have inflammation? Quick answers. No. I told you difference between necrosis and apoptosis. Necrosis shows you inflammation. Apoptosis does not show you inflammation. Answer is no. Then, like you said, caspase dependent. So tell me the name of the number of all the caspases. What are the caspases that are going to come under initiation? It is going to be caspase 8, 9 and 10. What are the caspases that come under execution? It is going to be caspase 3, 6 and 7. Out of these, which is the most important caspase? Caspase number 3 is going to be the most important. Very good. I can see some quick and correct, accurate answers coming. Okay, then I've written a number of molecules. You will tell me the first category, are these pro-apoptotic or anti-apoptotic? P53, BAX, BCL, XS. These are all going to be pro-apoptotic molecules. They carry out apoptosis. Whereas BC, remember that entire mnemonic? BCL2, MCL1, BCL, XL, all the LL alphabets had to lower apoptosis. This means they were anti-apoptotic. Perfect guys. Next, you will tell me, marker, write this, I taught you today only. What is the marker of apoptosis? What should I write? Annexin A1 or annexin 5? For apoptosis, I should write annexin, penta-annexin 5. But if I am asked molecular marker, then my answer is going to be CD95 or FAS. Step ladder pattern, where is it seen in? Options that you have. Is it seen in apoptosis? Is it seen in necrosis? Or is it seen in both? Best answer, ma'am, will be both. But if you ask me where is it most commonly seen, it is most commonly seen in cases of apoptosis. Perfect. You finished the entire summary. This means you have done your revision also. And now I can move on with the next topic, which is a newer topic in Robbins 10th edition. Lot of details were added, and that was the newer cell deaths. To be very precise, I am going to teach you two under it. One is going to be necroptosis and the other is pyroptosis. In your university exam, viva mein to nahi pucha jayega. These are not viva exam questions. These are theory exam questions, and both of them are going to get you short notes. They're not worthy of a long question also. Long question wala I have taught you. Necrosis can come as a long question. Apoptosis can come as a long question. So we studied them in a lot of detail. These are newer cell deaths. They will come to you as short notes. Let's get going. The first name looks so nice. Necrosis and apoptosis, if I join them, I think what I have in place is a necroptosis, and that is exactly what I'm going to tell you. This is truly, and I'm not joking, this is not just for the heck of it, truly it is a combination of necrosis as well as apoptosis. You know, when you write your theory exam and when you write, say you get a short note, you write necroptosis, if you write it like this, also what you should be learning with me, which I won't tell you again and again because I don't want to repeat things, but also the way I sometimes write is very important for you to do the same thing in the exam. Like for example, if you have written annexin 5, you're writing a short note on apoptosis, but on the side you can say, however, annexin A1 is a marker of hairy cell leukemia. These kind of boxes you are not making only for your learning, you have to convey it to the examiner who's checking your answer sheet. When I check answer sheets, this box will attract my attention, and I'll be very impressed that this student is not only having information of general path but is also having information of hematology. So these are the kind of, the way we write is exactly how you also have to write your answer during the exam. So I'm making sure that we are writing bullet points also, so just don't take it as, you know, random lecture, but also how you have to write your answer. So let's move forward, and now when I say necroptosis, the first thing you will convey to the examiner is it is a combination of necrosis and apoptosis. Then you would want to tell what not. So I can say it's like it's a thief. It has stolen little things from necrosis, little things from apoptosis, and it has presented a new cell death. So what has it stolen from whom? Necrosis. You will tell me, does necrosis have inflammation? Yes, ma'am. Necrosis had inflammation. So does necroptosis have inflammation? Yes. What has it stolen from necrosis? The ability to cause inflammation it has stolen. What has it stolen from apoptosis? Right now all of you were telling me that ma'am, apoptosis is caspase dependent programmed cell death. Ye to pata hai, we will never forget it. I will say okay, steal that definition, but change one word. You are calling it programmed cell death. Apoptosis was programmed cell death. Necroptosis is also programmed cell death. But now remove the word caspase. This is known as caspase independent programmed cell death. This does not use any caspase. Good for you, na? You don't have to learn all those 8, 9, 10, 3, 6, 7 numbers, nothing. Gone, story out. There is no role of caspase over here. So what has it stolen from apoptosis? Programmed cell death. But what has it put special from its own side? Necroptosis is caspase independent. When you solve MCQs, this is the question which will come 99.9% of the times. Necroptosis is caspase independent programmed cell death. The stealing game is not over. If I have to make a new term, let's assume, let's do some hybrid terms over here. If it's, I don't want to call it necroptosis, ma'am, it's a very simple name. Let's call it something else. Can I take the word programmed from here, and can I take the word necrosis from here? And now Robbins in the 10th edition says it is also known as programmed necrosis. They tried to act smart, but I don't think they have been successful because it becomes very obvious for us. It is also known as programmed necrosis. Does it make sense? I've taken the programmed word from here, I've taken the necrosis word from here, and hence I get the other name. The stealing game is not over. Now you will tell me, let's ask you a question. Apoptosis was what? Physiological, pathological, or both? Does apoptosis only occur in diseases, or can it occur in anyone? I just told you a while ago, if you were listening, apoptosis can occur in anyone. It can occur normally also, means it could be physiological, and it could occur in diseases also, means it is going to be pathological. Now, one more trick, although I should not be telling you this, but it is known, so why should I also hide it? It is known by everyone. When you are studying and when you are trying to learn, you try to make your information very concise, that everything should be on one page so that I remember all the points. I don't have to make 20-page notes. I have to make very limited, one page notes I have to make. But when I go and write the same thing in the exam, I have to convert that one page into 10 pages. The story in the exam is different. So right now I will write everything on one page, that okay, I've written the other name also over here, I've written the information here, I've written the next, but this can become separate lines. I should not be, obviously saying this, but it's very well known fact that the number of content that you write, amount that you write in the theory exam also makes a difference. You can't wrap up if necroptosis in this much, examiner will say nahi aata. But if you write the same information in every alag separate line, examiner will feel that you are having more knowledge. So this is an unfortunate but a well-known fact of medical profession. You have to increase the number of sheets, but you don't have to write nonsense in it. You have to write good content in it. Okay, so it can be both. Very good, you've given me an answer. So now give me examples. Normally, when does necroptosis occur? Imagine you are a 1-year-old baby and necroptosis is just casually, normally happening in your body. When would that happen? It can happen during any mammalian growth plate formation. So who will tell me what is growth plate? Growth plate, where is it present in my body? And for the formation of growth plate, someone needs necroptosis. Normally, yes, growth plate is present in the bones. Now, the bones have to grow, right? We all know bones keep on growing throughout, not throughout, but for the first 20 years of your life, your bone growth and your height and all has to happen. So, every bone has a growth plate. Every bone, I'm drawing a very basic bone, dog bone jaisa bone I'm drawing, just for your understanding that every bone is going to have a certain growth plate, and growth plate will need necroptosis so that the growth of your body can occur. So this is a very normal thing to occur. But if I ask you pathological, that is, tell me the name of 3 to 4 diseases where necroptosis is happening. So first, let me write the name of the disease and ask you whether you know the meaning. Do you know what is steatohepatitis? I mean, hepatitis you know because it's going to be liver, hepatic. What do you mean by steato? Steato word in pathology and medicine means fat. So what you all casually call fatty liver, medicine में it is given a technical name called steatohepatitis. So when someone asks you that, okay, in fatty liver, what is the cell death happening? It is going to be the necroptosis. Second, next to the liver, we have the pancreas. So what happens in a case of pancreatitis? It is again going to be necroptosis. Okay, the third one, maybe you new kids on the block, you have not heard it, but never mind, I will teach you eventually. Reperfusion injury, guys. Do you have any vague idea of what is reperfusion injury? I'm not writing it because when I teach you in the correct chapter, I will talk about it for 20 minutes. Right now, I can give you a basic clinical scenario. All of you have seen a patient of a heart attack, of course, heart attack, myocardial infarction. Why does myocardial infarction occur? Because someone has a blood clot, ma'am, someone has atherosclerosis, his coronary artery got blocked, so that is why he had very severe chest pain, he went to the hospital, he got diagnosed with a heart attack. What do you think the doctor would do? Even if you have no idea, you're in a second year, you have never been to the cardiac department also, but as a basic doctor, do you want to keep the blood clot over there only, or do you want to open the blood clot so that the blood clot goes away and the patient gets his blood supply? Common sense tells me that you will open the blood clot. In some people, sometimes what happens is, as soon as you open the blood clot, either by putting a stent or by giving some medicines, as soon as you will reperfuse the patient, as soon as you will open the blood clot, you expected that the patient will start improving, but the patient starts dipping. The patient starts further deteriorating. That is what is called as reperfusion injury. It is not seen in every patient. It is seen in only some patients. But right now, I can only give you this kind of limit because I have not taught you myocardial infarction. When I will teach you, of course, I'll talk about it for 20 minutes. So reperfusion injury is that on giving therapy, the patient further starts deteriorating. That is reperfusion injury, and that happens in the heart because of necroptosis. Coming to the next one, have you heard of what is this virus, CMV? What knowledge do you guys have about CMV, guys? Please let me know. Yes, what is it about CMV? Cytomegalovirus. Do we all know? So I will continue on the next page. I have already taught you. So let me continue over here and teach you about what CMV does. Cytomegalovirus. It's a virus which I want to tell you. A virus enters someone's body. What is the first cell death that will try to kill it? You will say, ma'am, obviously, apoptosis, ज़्यादा सुना है. Apoptosis is the prevalent one. Apoptosis will try to kill it. Okay, so plan A of your body was, what is your plan A? This is you over here. Okay, this is you. Your plan A is, it is going to be killed by apoptosis. So you are very smart. CMV will come in my body. This virus will come in my body. I will kill it. You are acting like very smart. But cytomegalovirus is smarter. Cytomegalovirus says, as soon as I will enter into this person's body, he is going to be ready with apoptosis. He will kill me with a sword. And how will he carry out apoptosis? Because he has caspases, caspase dependent programmed cell death. So then CMV says that I will carry my shield. I will carry my shield around myself. It has something called caspase inhibitors. God has already given it caspase inhibitors. Now tell me, you were thinking, oh, I will kill it with my caspases. As soon as cytomegalovirus entered, did it help you or did it let you carry out apoptosis? No. So plan A ho pata hai? No, ma'am. Plan A fails. Plan A fails. So will you be able to kill cytomegalovirus? No. Then that means all of us should have had cytomegalovirus in today's date. If we can't kill the virus, I'm sure we have thought of always in life, keep a plan B ready. Your plan B was that, okay, if it is getting caspase inhibitors, it is not letting my caspase work, maybe I have a cell death which doesn't need any caspase only. Necroptosis, I will kill it with necroptosis because for necroptosis I don't need any caspases. So now tell me, how is it finally killed? It is going to be killed by necroptosis. This is the last sentence of Robbins which is written for this particular short note. I hope it is okay. How is cytomegalovirus killed? Is it killed by apoptosis or necroptosis? it is killed by necroptosis. You've understood why you could have killed it with apoptosis, but it was a smart one. It got caspase inhibitors. It's not letting you work. It's not letting your apoptosis work. So you went to plan B and you killed it with necroptosis. Is everyone okay up till now? Because now I'm going to tell you the toughest part, and that is the mechanism. But it's not tough for you guys, because if you survived apoptosis in the last class, which was so lengthy, for half an hour it went on, this is going to go on only for 3 steps. So now this is a particular cell, whatever cell, let's say what cell do you want to take, which organ do you like, guys? You say, ma'am, we like liver. Chalo, okay, this is probably the liver. This is a case of fatty liver, any cell, or maybe it's pancreas. So when you're saying this is a liver, you say that, okay, in the liver, the cell death, this cell is going to die. How, ma'am? By necroptosis. I will say, okay, there are going to be 1 step, 2 step, 3 step, and the cell will die. Is this okay? You have to kill the cell in 3 steps. We are going to do 1, 2, 3, death. That's it. So what is step number 1? It is the binding of TNF. So this is, I'm just drawing one random molecule TNF, and that TNF is going to come and bind to the receptor on the cell called TNF receptor. So there is going to be TNF and TNF receptor binding. These flowcharts are there in Robbins. Examiner expects that, examiner also, what do you think? Examiner has every word by word on his fingertips. He's also a human being. Someone who will check your answer sheet is a human being. No one can remember Robbins from first page to last page, but what examiners and teachers always remember are flowcharts. They are expecting that those Robbins flowcharts should be there in your answer sheet. They will not read upar niche, they will read that flowchart. So never miss out on making a flowchart in the exam. Don't start writing this like a short note in paragraph form. Always make a flowchart, then describe it in 4 lines in a paragraph. So if the examiner wants to read the paragraph, he can, but 99% examiner will only look at your flowchart. So the first thing is TNF. Who will tell me the full form of TNF? TNF stands for tumor necrosis factor. You are just starting with your journey of pathology, so you will be studying this a lot. TNF stands for tumor necrosis factor. All of us have this mediator. What will it come to bind at to? It will bind to the receptor. As soon as the binding happens, a signal is sent inside the cell. So if you want to extend, you can extend this entire thing. This is the entire cell, fatty liver ka cell that you're talking about. The cell says, oh, I have to now make a trio. The cell is told that you will have to make a trio. 3 things will have to come together and make a complex. What is that complex? One is known as RIPK1. Second molecule is RIPK3. And the third molecule is procaspase 8. Let's understand them better. First question to you will be, what is RIP? It's not that rest in peace. Although it's very easy to learn that yes ma'am, it must be rest in peace, because ultimately the cell is also going to undergo death and is going to rest in peace. But from pathology point of view, what is RIP? It is going to be receptor interacting protein. RIP is going to be receptor interacting protein. Is that okay with everyone? RIP. And what is the K in front of it? It's an enzyme. Receptor interacting protein kinase. So one molecule that comes is RIPK1, then his family member RIPK3 comes, and the third molecule that comes is procaspase 8. And you will say, ma'am, you have ditched us. You have, spoken, you've not told us the truth. You were lying to us, because again and again you were saying necroptosis is caspase independent. Necroptosis has nothing to do with caspase. We will not use the word caspase. And as soon as you started telling me the flowchart, you started using the word caspase. Have I used the word caspase? I'm still honest. I have not used the word caspase. I have used the word procaspase, because procaspase is always an inactive form. Will this ever change into caspase 8? No. So remember this. This will never ever change to caspase 8. Because tell me guys, let's take how many of you are up and awake and how many of you have given up. If this by chance changes, kuch hua body mein some problem happens, if this changes into caspase 8, would you still want to call it necroptosis, or would you now want to call it apoptosis? Batao. what would you want to do? I think if Caspase word starts coming, then you can't use the word necroptosis. Then you will say, ma'am, it has changed into apoptosis. But till the time I'm using the word pro-Caspase, I can say, yeah, that wo chalega. So necroptosis is what? Necroptosis is Caspase independent. The inactive forms to can be there, na? Pro-Caspase can still be there. Perfect. As very good. Dr. Anish also says that pro hoga, so we will say necroptosis. If it changes into Caspase, then apoptosis. Great. Step number 2 done. As soon as this trio will form, and one question will come to you, ma'am, why the confusion? When Caspase changing doesn't have to happen only, why are you even keeping the inactive form? Hata do na. It's something like a Fevicol. You have to combine two things. If you have to join two things, you will have to put Fevicol in between them. I want to join RIPK1 and RIPK3. These two family members, these two brothers I want to join. Who is working as a Fevicol between them to join them? That is the job of Procaspase 8. As soon as Fevicol is put and this complex is formed, they go and cause something known as MLKL phosphorylation. Please don't ask me the full form of MLKL, because no examiner will ask you. You will not have to write it in the exam. It is, this full form is like 1.5 sentence. इसलिए no one wants you to write it, okay? This phosphorylation will finally go and cause cell death. This means that the cell membrane is now going to die off, and that is what we wanted. We wanted 1, 2, 3 death, and that is what has happened. Now everyone do 1, 2, 3 death, and quickly, without looking at it, revise with me. What is 1, 2, 3 death? Necroptosis short note is done. So tell me, first binding is what? TNF and TNF receptor family have to bind. Second, there is a complex formed, RIPK1, RIPK3 and pro-caspase 8, no caspase. Third, there is going to be MLKL phosphorylation. As soon as this MLKL phosphorylation occurs, the cell is going to get damaged. That is what you wanted. Do you have enough material to write for a short note? Preparing you, like last time also I told you how to frame answers. Do you remember, guys? Because I'm not going to tell you in every class. Wo copy paste for all of your entire path micro syllabus. Introduction, body, summary. Do you remember that way of writing? First, you will have introduction. Your introduction should look something like this. Necroptosis is a cell death which is a combination of necrosis and apoptosis. It is also known as programmed necrosis. This is your introduction. Then in your body, you will start describing what from necrosis, what from apoptosis. Then you will write it can be physiological as well as pathological. Then you will explain the entire story of cytomegalovirus. Then you will explain the entire mechanism. This is the body of your answer. Then your summary. Remember I told you your summary should have 5 bullet points. Tell me those 5 bullet points that you will write. If I was a student and घर से नहीं याद करके जाना, what are the 5 bullet points that I will write for everything? No. Put your common sense over there that, okay, what are the 5 most important things that I would want to teach? Think of yourself as a teacher. Think of yourself that you are sitting over here in my place and you had to teach me a crash course of necroptosis. What would have been those 5 points that you would have said you have to know it? Number one, you would have always told me that, oh, this is Caspase independent programmed cell death. So summary ka first bullet point is this. Second, you would have told me it can be both physiological and pathological. Under physiological, you would have definitely told me mammalian growth plate formation, and under pathological, you would certainly tell me the story of cytomegalovirus. Finally, you will say that there is involvement of a 3-step procedure for cell death, out of which there is a complex formed called RIPK1, 3 and procaspase 8. Your 5 bullet points are done. If you start, many students don't, and only students who are sitting over here will know this trick, that this is how you should write the answers. Trust me, I can guarantee. Once the examiner starts looking at your answer sheet and your examiner knows that after every question, this student has written a 5 bullet summary, automatically to save his or her own time, he will start reading your summary only. That अच्छा इतना अच्छा आंसर फ्रेम करा है तो he has a lot of knowledge. That gives a very good impression on the examiner when he's actually checking your answer sheet. So abhi I'm just telling you that. Slowly I will also tell you further how to write your answer. There is something known as heading, then subheading, then subheading. Gradually I will guide you towards that. Abhi your basic is intro, body, summary. That is how you go. Necroptosis is done. Are you ready for the 4th cell death? That is pyroptosis. Necrosis, apoptosis, necroptosis. Now we come to 4th one, pyroptosis. Again, what should be my introduction line? Explain the word in one sentence. What do you mean by pyro? Anyone? If I say there is a patient, he has pyrexia, or this is a pyrogenic molecule. Pyrexia. What do you mean by that? It means fever, okay? Yes. So when I say patient has pyrexia, means his body temperature is up. He has fever. And ptosis over here is not वो eyes वाला ptosis, eyelid वाला ptosis नहीं है. Ptosis over here means जैसे apoptosis, necroptosis, pyroptosis. So this basically means a kind of a cell death. So now you will say that pyroptosis is a cell death which is accompanied by fever. As soon as you write this line, examiner knows that, oh, this student has clarity of the terminology. Terminology is clear, then rest of the thing he will obviously know. So let's start. And now if I say what is the cause, why? See, I have committed two things. I am making a commitment right now, and by the end of this slide, I will fulfill my commitment. My commitment is that at the end of this, the cell will die. Right at the end, when I reach, the cell will be dead and the patient will have fever. These are my two commitments. Let's see how I fulfill them. Why will someone have fever? Because of some kind of bacterial infection, ma'am, this is happening. It can be associated with any bacterial infection. But what the examiner wants to read, what is written in Robbins, is going to be Shigella and Salmonella. Shigella and Salmonella. That doesn't mean these are the only two bacteria that can cause it. Any bacterial infection can cause it. Let's assume, let's make one bacteria. This is a Shigella or Salmonella. Which one do you like more? Mostly students write Shigella because mostly questions come on Shigella. So let's assume that this is a bacteria, this is Shigella. Oh, as soon as Shigella comes into your body, this is your cell, okay? This is your cell, and your cell says, you know, you are so humble and you have so much mannerism that Indians have been taught that even if a bacteria comes in your body, you are taught you must receive him, you must treat him, you must be a good host, you must make him sit in your body, offer him food, offer him water. So Shigella ko bhi अच्छे से we are going to treat. We are not going to chuck him out of our house. As soon as, let's assume this is the cell, this is the human being over here, and as soon as Shigella comes into my body, I believe in, okay, this is my guest. I must receive the guest. Who is the receptor who is going to receive it? So remember, bacteria is going to be received by the nod receptor. Bacteria is going to be received by the nod receptor. So here is the nod receptor, here is the bacteria, and we all believe in what? Indians believe in Atithi Devo Bhava, that, oh, this is my guest and I must treat him better than a family member, right? So we have received the bacteria, but we are not that nice also. Receive kar diya, we gave him welcome drink, okay, drink, eat food, but after some time, this bacteria will start killing you only. And that is when you will realize, oh, I got the wrong guest inside my body. But what will this bacteria do? As soon as the bacteria says, oh, this human being is very nice, he's receiving me with a nod receptor, what do I do? So this goes and then activates something known as inflammasome. That is what it's going to do. It will go and activate inflammasome. What is inflammasome, ma'am? Inflammasome is a molecule which will further go and activate certain caspases. The story of caspase is back in your life. Which caspases will be activated over here? Caspase 1, 4, 5 and 11. In some textbooks it is written only 1, 4, 5. In some it is written only 4, 5, 11. Please note, I have taken this from the best journal of our country, of the world, not just the country. Globally it is 1, 4, 5, 11. These are the caspases which are activated. And what do you think they are going to do? What was the commitment? You received the bacteria, but the bacteria has come to kill you. These caspases, all these 4 caspases will now go, commitment number 1 fulfilled. They will cause cell death. Commitment number 1 done. Commitment number 2 is fever. Ma'am, who causes fever? Caspase 1 out of these causes fever. This caspase 1 will go and activate interleukin 1. And now I am telling you interleukin. Do we all know what is interleukin? Interleukin is a molecule. Whenever interleukin 1 level will rise in your body, you will land up with fever. Now, whether that fever is because of bacteria, or whether it was because of COVID, or whether it was because of any other virus, parasite, Fever हुआ मतलब what is the molecule that has gone up in your body? Interleukin 1. How do you learn? How will interleukin 1 get activated? Ma'am, caspase 1 will activate interleukin 1. 1 for 1. Commitment number 2 done. Patient को fever भी हो गया. I told you in this one slide I will fulfill my 2 commitments. So tell me, which are the caspases that cause the cell death? All of them, ma'am. 1, 4, 5, 11. But which is the caspase that causes fever? It is caspase 1 that causes fever, and pyroptosis is over. So, can you have spoken so much about caspases? Can you all give me a caspase revision summary now? Again, whenever, now this is not my summary table. This is a summary table for you, and you will also go and write this in the exam. If you get a question on apoptosis or you get a question on pyroptosis, you will write the full table so that examiner knows कि उसे ये तो आता है, but he also knows, or he or she knows, the other caspases also. Tell me, what were the caspases that you had in necrosis? Did we have any caspase in necrosis? Think coagulative necrosis and liquefactive necrosis. I don't remember any caspase. Do we have any caspase in necroptosis? Ma'am, in necroptosis, तो your definition was only caspase independent programmed cell death. But do we have any pro-caspase? Pro-caspase 8 is present, but caspase is not present. Further, the main caspases were in apoptosis and pyroptosis. In apoptosis, you've already told me for initiation 8, 9, 10 and for execution 3, 6, 7. Pyroptosis, I have told you right now 1, 4, 5, 11, out of which are the ones which are going to cause cell death? Ma'am, all of them cause cell death, but which is the one which is going to cause fever? It is going to be caspase 1 for fever. Your full cell death summary is done. So if I have to ask you, what were the 4 cell deaths that you studied? Because finally it's over. Last class you studied necrosis, apoptosis. Today you have studied necroptosis, pyroptosis. One last cell death which only students who are studying with me would know, because you will not find this even in Robbins. But if you write this, then the examiner will obviously know कि अच्छा सोचो Robbins से भी अगर ज़्यादा कोई लिख दे तो how happy can an examiner get? And that 5th cell death is known as Anoikis. Why am I teaching you this? Because I am not only preparing you for your university exams, वो तो होना ही है, but I want, if you are studying so much, then you should get MCQs also, right? And you should get a good 90% above strike rate in your MCQs also. Then these are questions that you'll get in your MCQs. What is Anoikis? Anoikis is also a cell death. You know what type of a cell death? It's a cousin brother of apoptosis only. जैसा जैसा apoptosis था, उसी का somewhere cousin brother of apoptosis is Anoikis. And one line, you don't read all this. Understand first. You tell me, think of yourself in 2 situations. Okay, who's the last one who messaged Dr. S.A.? I don't know your full name. But okay, Dr. S.A., right? So Dr. S.A. has been put in 2 situations. When, you tell me guys, when will he or she be happy? One situation is when I have put you in vicinity of your best friend and your friend circle in your hostel. All of you are together. You are going out for movies and lunch and dinner and enjoying and having parties. Will you be happier then? Or if I put you inside one room, 4 walls with one textbook, that is Robbins, no social media, no friends, no family, no one to talk to, just you and your Robbins, that is isolated from your environment, when do you think your survival chances will be more? Obviously, ma'am, when I'm talking to people, when I'm with my family, when I'm with my friends, I will be happier. If you put me with Robbins in one room, I will not survive for even one day after that, right? So same happens with cells also. Till the time the cells are in their natural environment, means all the cells are together, any one random epithelium I have drawn, one columnar epithelium I have drawn, till the time the cells are together, they will survive. If I pick up one cell and I put him in isolation over here, I put him in isolation over here, do you think the cell will survive? No. So can I say loss of natural environment can cause cell death? And that is Anoikis. So if I put someone in ice, that is why I always tell students, it is very important to study in your MBBS, but never consider that I have an exam, so I am going to deactivate all social media, I'm not going to talk to my family, not going to talk to my friends, and I'm going to sit inside one room for 4 months and then see what comes out. Please create a balance for your mental health, for your physical health, and just for the health of everyone around you. create a balance. We don't want you to be undergoing Anoikis. We don't want that there should be complete collapse because you have lost your natural environment. Please stay in your natural environment. Everyone's understood Anoikis. If I bring a cell out of the natural environment in isolation, the cell will die. That is known as Anoikis. It is a type of cell death. Which type of cell death? That is apoptosis. So no, this will not come to you as a short note. Whenever you are writing apoptosis, if you want to give that extra information to your examiner, you can write Anoikis. If not, chalega, no one's expecting in your university, but when you go to your MCQ bank, you will find this. Now that I said MCQs, maybe 2 questions will just help us know that whether you were listening to me or not. Which of the following is incorrect about necroptosis? Also, reason that I'm making you do MCQs, there are 3 reasons. One, how many of you get MCQs? 20 MCQs many people get in their college exams only. One reason. Second, I want you are also simultaneously preparing for, I'm preparing you for university and for NEET PG, FMGE, whichever paper you're doing. So I'm preparing you for that. And third, after this, many students are asking me, ma'am, should we also view the recorded videos? So my answer is no, because whatever MCQs I have taught in recorded videos, I am teaching you over here also. So that koi FOMO nahi rahe ki usme to tha and idhar nahi hai and all of that. This is your only video source then that you have to look at all the time. So tell me, what is incorrect about necroptosis? Tell me true and false. Is it Caspase independent programmed cell death? That's true, it is. Is RIPK1 and RIPK3 a complex? That is also true. Is Caspase 8 required? Ma'am, necroptosis के साथ what a blunder. Caspase word you can't use. This is incorrect. This is the answer over here. Very good. Is mammalian growth plate formation following necroptosis? That is also correct. The only wrong statement over here is option C. Very good. Dr. Tushar, Dr. Anish and Dr. Om. Perfect. Coming to the next. Another question. What is incorrect about pyroptosis? Right now we studied. Is it seen in response to Shigella? Yes. Pyro, fever, bacteria, correct. Is toll-like receptor used? Who was receiving? When bacteria comes, is it the toll-like receptor? No, I told you it was the nod receptor that was being used. This is the false statement and I have found the answer over here. This is the answer that we have. Let me read others. Is pyroptosis, is Caspase 1 required? Yes, 1, 4, 5, 11. Does Caspase 1 activate interleukin 1 for fever? All of these are correct. The only wrong one is the second option. Very good. All of you got this also right, which means your entire cell death story is done. I taught you all the negative things first. कि cell मर गया, cell died, necrosis, all that is done. Today I will take you into positivity. Cellular adaptation. Do you think that your body is so weak that one oxygen level drops and you will die in 1 minute? No. Your body will first always adapt. If you can't adapt, then you will die. That's a later stage. First, your body will always try to adapt. So please remember that whenever, and I've told you, make this flowchart all the time, whenever there is injury, what is the first thing that your body does? Your body does adaptation. And if the adaptation fails, maybe ma'am, the injury was so severe that I could not adapt, that is when your body undergoes a cell injury and that is when your body undergoes cell death. So what is the first stage? It is always cellular adaptations. Let's start. How many cellular adaptations? Whenever you get a short note, acha, now either sometimes examiner gives long questions are also given as short notes. You have so much to write, but examiner is asking you for a 4-mark, 3-mark short note. Then you have to put in main information. Sometimes full topic comes as a short note, or sometimes individual topics also come as a short note. You have to be prepared. Long question I have not seen in any university. So either you will get a full short note, which is good. You have to write 5 lines about everything, or individual topic comes. So you have to be prepared for both. This is a very short note type of a topic that we are doing. Let's do cellular adaptations. I can see total of 5, but guys, I am only going to teach you 4, and many of you will say कि ma'am Robbins में 5 थे, आपने 4 पढ़ाया. There is a reason, and I'll tell you that reason first hand. Dysplasia, you know what is, in layman term, what is dysplasia? Dysplasia is pre-cancer. And now this is not the chapter to teach you pre-cancer. Cancer के बारे में we will talk in neoplasia chapter. Then I will teach you dysplasia for half an hour. Right now, you will not understand anything. So right now, I will only teach you the first 4 cell deaths. But I've written over here that in your final university exam, if you ever get a short note, you have to write all 5, okay? So we are going to study the first 2. Let's start from here, hypertrophy and hyperplasia. I've got you a small little diagram so that visual, and draw this diagram in your exam. Your examiner will love to see this in your answer sheet because this is there somewhere in Robbins also. What have I done? These are normal cells. How many number? You can see 1, 2, 3. I have drawn 3 cells. In the next photo, ma'am, again I can see 1, 2, 3. Number is the same. But what has happened to the size of the cell? What do you think has increased in this photo? Size of the cell has increased or number of the cell has increased? I think the size of the cell has increased. If there is an increase in the size of the cell, that is hypertrophy. Now look at photo number 3. I can see 1, 2, 3, 4, 5. I can see the number of the cells have increased. If there is an increase in the number of the cell, that is going to be hyperplasia. Now you've seen the photo, now write it with me. What is the difference? Hypertrophy is an increase in the cell size. Hyperplasia is an increase in the cell number. Basic definition. Plasia word will always mean number and hyper means more, increase in number, right? But why does it happen? So if this is one cell, how will it increase in number? How will it become 2? Can you tell me from your school knowledge, biology knowledge? One cell becomes 2 cells. Then these 2 cells will now change into total of 4 cells. Then from 4 to double 8, 8 ka double 16, 16 ka double 32. So can I say, if someone asks you what is the mechanism of hyperplasia, you will say the mechanism is cell division. The mechanism is cell division, and in biology, cell division is known as what? It is known as mitosis. Simple. How does 1 divide into 2? Mitosis. 2 into 4, mitosis. 4 into 8. Double hota jayega. 1, 2, 4, 8, 16, 32 and so on and so forth. Everyone okay? What is the mechanism of hyperplasia? It is mitosis, division. What is the mechanism of hypertrophy? Ma'am, why is the size of the cell increasing? And this, think of this, because when you put day-to-day examples into it, you understand better. So let's put a day-to-day example for anyone who's fond of weightlifting or in generally is into fitness and likes going to the gym. You tend to see, you don't see changes in one day or 1 week. It takes many months. And then what happens to the size of your muscles? When we say, oh, this person has biceps or this person has triceps, what has happened to the muscle? The muscle has become more in number? No, muscle can't divide, na? The muscle has become more in size. So when we say this person has biceps or triceps, we say that that person has had hypertrophy of the muscle. I am teaching you ulta. What is written in the book, you will anyway read that. I am teaching you opposite because I want you to understand. For that, you will have to tell me a little bit of biochemistry. In biochemistry, did you study central dogma last year in first year? Did you study DNA changes to what? DNA changes to RNA. What is that process known as? This is known as transcription. DNA changes to RNA is known as transcription. Then what does RNA change to? RNA changes to protein. Very good. And this is known as translation. Do we all remember this? And now apply it. When you say, ma'am, bodybuilder has biceps and all of that, so biceps matlab muscle size has increased. What do these people keep having? They keep having either protein, or they keep having a lot of eggs or rich in protein sources, protein powders, etc, etc. So basically, if you want to increase the size of the muscle, you will need protein. Do you think it is only possible that you keep eating protein in the form of eggs and chicken and protein powder and your muscle will become big? No. Your body also has to do some work. Inside the muscle cell, DNA to RNA change will be more, RNA to protein change will be more, then the muscle will become big. So you tell me, if you want more muscle protein, you will say, ma'am, this entire process has to become more. More of DNA has to change into RNA, then only it will change into protein. So what should I increase? What is the first step you will have to increase? You will have to increase transcription. This means, on asking what is the mechanism of hypertrophy, the mechanism is going to be increase in transcription factors. That is what is written in textbook in Robbins, and no one understands ke kya likha hai. Why do I need increase in transcription factors? Because common sense. If the transcription factors are more, this means DNA will change more to RNA. This means RNA will change more to protein, and if protein will be more, the muscle will keep becoming bigger, hypertrophy. So the increase in transcription factors, and then you have to know the 3 transcription factors that increase. What are they known as? They are known as GATA, NF80 and MEF2. GATA, if you want to be very good in learning, then this is what is written in Robbins. GATA4, NF80 and MEF2. ये 3 transcription factors हैं. These are 3 transcription factors. They will increase automatically. Hypertrophy will occur. Are you okay with mechanisms? What have I taught you? The short note is not over. See, in one go, I'm teaching you 2 short notes. Either you will get a short note on hypertrophy or you will get a short note on hyperplasia. लिखना ऐसे ही है. You have to compare and write in the exam, because examiner expects that whatever I may ask you, you will have to tell me the other one also. So hypertrophy is going to be increase in the size. Hyperplasia is increase in the number. Number is increased because the cell is dividing. Size has increased because the transcription has increased. Now let's understand better with the help of examples. And I am going to teach you certain common examples. Those examples where both things occur. Common examples, hypertrophy also occurs, hyperplasia also occurs. Have we all heard of gravid uterus? Gravid uterus, gravid means what? Gravid means, yes guys, pregnancy. So you all know, pregnancy mein the abdomen becomes so big, basically the uterus becomes very big. So is it just an increase in the size of the muscle? Or is there also increase in number? It is both. It is going to be hypertrophy plus hyperplasia. But ma'am, this is good for theory exams. For MCQ exam, they will always say either they will mark both or they will say no, select one. And then in that situation, which is more, which is happening more in a gravid uterus, it is going to be hypertrophy. Is that okay with everyone? Yes? Yes? Okay guys, let's read further. Now let's look at one more example. Breast development. And you know, breast development happens in a female. It is, although the common man believes that breast development only happens at the age of 12, 13 during puberty. But no, breast development happens so many times. Number one, it happens at puberty, and the next time it happens massively is of course going to be during pregnancy, because hormone changes hota hai, pregnancy, lactation and all those hormone changes. So what are the changes that happen in the breast? Again, both. It is going to be hypertrophy as well as hyperplasia. But if you have to select one in an MCQ, it is going to be more of hyperplasia. P puberty, P pregnancy, P plasia zyada hota hai. So now you are ready for theory and for MCQ exams. First, you will write a short note that pregnant uterus shows you both, but it shows you more of hypertrophy. Breast development during puberty, pregnancy shows you both, but it shows you more of hyperplasia. Have you done the common examples? Because now I will start with individual example. Only hypertrophy, only hyperplasia. So I don't think I have to tell you this. Number one example of hypertrophy will be bodybuilders. And these days, thanks to Instagram, everyone is a bodybuilder. Everyone is a fitness enthusiast, right? Everyone has to make reels. If you don't make a reel, this means you are not a fitness enthusiast. So bodybuilders mein, the muscle size that is increasing, obviously which muscle? Skeletal muscle. Ma'am, why are you writing such a common sense thing? Are you becoming like us, that you are trying to increase the number of pages so that examiner ko lage, oh, what a big answer? No, this I'm writing purposely because once a question came in the exam, an MCQ came, that bodybuilders show you hypertrophy of smooth muscle or bodybuilders show you hypertrophy of skeletal muscle. And common sense guys, biceps, triceps, what are they? They are skeletal muscles, na? So sometimes such easy questions come that you start doubting yourself. Okay, itna easy bhi pooch sakte hain. They do that. They have done that so many times. So remember bodybuilders, and even in your theory you will write skeletal muscle increases. This is common sense example. Now let me tell you an example which is different, which you will not understand from the textbook, and I hope I can make you understand now. That is proximal to obstruction. What do you mean by proximal to obstruction? Let's make an example. Let's draw one organ. Can we draw urinary bladder? Any other organ coming to your mind? Kahan obstruction karaye? Chalo pehle ma'am, this is the urinary bladder and you want to make an obstruction over here. How will the urinary bladder get obstructed? Some kidney stone came and got stuck over here. Any other organ you want to cause obstruction in? Okay, if you want to cause obstruction in the heart, Yes, fine. Okay, heart may you want to cause obstruction, and intestine may also, let's say we want to cause obstruction. Chalo, as 3 organs ka example I have taken. Heart, I have, my artistic skills are not very good. This is the best diagram of the heart that I can make. So isi mein I will divide the heart into 4 chambers. Okay, I will divide the heart into 4 chambers. You know, left atria, left ventricle, right atria, right ventricle. And what have I done? From the left ventricle, what goes out? From the left ventricle, ma'am, the main blood vessel goes out, that is aorta. I have caused an obstruction over here. I have caused aortic stenosis. Aortic valve has become smaller, closed, aortic stenosis. Okay, then over here I have made an intestine. In the intestine, why is there an obstruction? Unfortunately, patient has a cancerous growth. There is a cancer causing obstruction. So ma'am, why are you teaching us obstructions? Because how is your body going to adapt? See, if your body has an obstruction, will you die? Next day you will die? No, na. If someone has aortic stenosis, they can live for many years. Along with kidney stone, for this stone, at least for 6 to 8 hours, patient will have pain, but he will not die, na. He will have pain, he will suffer with pain, but he will adapt. How does your body adapt? So tell me, will the urine be able to pass out? No, because the stone is there. All the urine will start getting accumulated here. The organ will start becoming big in size. How will the organ adapt? By hypertrophy. So what has the hypertrophy occurred? Proximal to obstruction. Prior to proximal to obstruction, how will the urinary bladder adapt? There is going to be hypertrophy. Okay, similarly, if there is aortic stenosis over here, the aortic valve is closed. How do you think the proximal to obstruction, how do you think the left ventricle filled with blood, ma'am? There is going to be left ventricular hypertrophy. Left ventricular hypertrophy. Next, in the intestine, if there is a cancer, if there is a cancer, do you think stool and feces will pass? No, ma'am. Cancer has obstructed. How will the intestine adapt proximal? There is intestinal hypertrophy. So now, if you say bile duct or if you say any other organ of your choice, kahin par bhi you say obstruction has occurred, I will ask you, how is your body adapting? What is happening proximal to obstruction? You will say there is hypertrophy happening proximal to obstruction. Are we okay with examples of hypertrophy? Because I can now take you to the examples of hyperplasia only and only hyperplasia. And I've got one example in women and one example I will tell you for men. Simple, one for men, one for women. Equality maintain karte hain. So the first example for women that I have is going to be endometrial hyperplasia. Perfect. Okay, endometrial hyperplasia. Before that, I've got a question from Dr. Anmol who says, can a neuron show any of these adaptations? Yes, it can, but thoda sa you will have to wait for that, because neurons are cells which are a little different working. Like remember, for apoptosis also, neuronal apoptosis was a little different. So when we go to the next chapter, that is inflammation, after I've taught you all these small topics, in that I will tell you your entire body and I will divide it into pool of cells, that okay, these are the cells which can divide, these are the cells which cannot divide, these are the cells which are once formed and then you die with them. So I will give you a full understanding of which cell comes under which one. But currently, with the knowledge that we have, Dr. Anmol, right now till here, if you ask me, can neurons undergo adaptation? Yes, they can. They very well can, and I will tell you when the right time comes. We will read a table of permanent and labile cells. Usme you will get all your detailed answers. Coming back, endometrial hyperplasia. So let's draw. As I said, artistically I'm not very good, but if you are not good, then you should take your motivation from me, because with these artistic skills, I also gave my pathology micro prof and I got a distinction. So if I could draw such baby diagrams and get, so can you also, right? So don't feel if you're not artistically good, then you will not be able to. So this is the best uterus and cervix and ovaries that I can make, right? Now over here, I am saying endometrium is becoming hyperplastic. This is the endometrium. Let's label it. I am saying this endometrium is becoming very mota, very thick. Hyperplasia because of increase in number. Due to what? Which hormone causes it? Due to increase in which hormone? In women, it is due to increase in estrogen. Whenever estrogen increases, endometrial hyperplasia occurs. Increase in estrogen, increase in endometrial thickness. Now your next question is, ma'am, why is estrogen increasing? Tell us the reason. It could be so many reasons. Now this increase in estrogen could be, see, let's assume she has some PCOD, some hormonal problem. Let's assume she's taking some medicines, she's taking some oral contraceptive pills, or she's taking some other medicine which has resulted in increased in estrogen. Maybe she has some liver problem. Why am I not writing all this? Because no one will ask you right now. This is a separate chapter, but I'm giving you an option that, okay, maybe she's taking some drugs, maybe she has some polycystic ovarian disease, PCOD, which is very common nowadays. Maybe she has some other hormone problem because of which estrogen increases, but they will give you a question of example, maybe she has a tumor in the ovary. ये इनका favorite question है. So one answer of yours could be, it could be because of OC pills, it could be because of polycystic ovarian disease, it could be because of an ovarian tumor. And then you're like, ma'am, ये कैसे हुआ? If there is a tumor in the ovary, you mean to say that tumor is increasing estrogen levels? Yes. And that estrogen is then going and acting where? It is going and acting on the endometrium and causing endometrial hyperplasia. Exactly. I would have been in your place, I would have drawn this diagram. And once I draw this diagram, trust me, the examiner is not interested in all this. He's going to look at this diagram and he's going to tell you, yes, so can you tell me which ovarian tumor can do this? That tumor is a granulosa cell tumor. Granulosa cell tumor of the ovary is, I will, right now you're not studied, but let me tell you, granulosa cell tumor, how I make you learn in the female genital tract will be, granulosa cell tumor occurs in grannies. Grannies or grandmothers means it occurs in postmenopausal women, 50, 60, 70-year-old women. So tell me, do you otherwise expect a 65, let's say 65-year-old female, do you expect she should come to you with any estrogen at all if you do her blood test? Of course not, ma'am. At the age of 65, to let her rest without hormone imbalance. At the age of 65, no female should have more estrogen. But if a 65-year-old female comes and her blood test is showing lots of estrogen, which ultrasound will you do? You will say, oh, let's get an ultrasound of her abdomen. Let's see, does she have an ovarian tumor? Does she have that granny wala tumor? That is granulosa cell tumor. That will increase estrogen. That will then go cause endometrial hyperplasia. What do you think female will have? How will she come to you? She has no idea she has granulosa cell tumor. She doesn't know she has estrogen. She doesn't even know she has endometrial hyperplasia. What complaint will she come to you with? What are the clinical features? She's going to come to you with bleeding. Do you think a 65-year-old female should be having menstrual cycles? Of course not. She's bleeding at the age of 65, bleeding from her vagina, bleeding per vaginum. She will be very tensed that at 65, why am I bleeding? You do her ultrasound, you're like, oh, she has endometrial hyperplasia. Then you further do ultrasound, you're like, she has an ovarian tumor. That is how you work up a patient. So then what should you do? You should just give her some drugs to stop her bleeding. You will say, okay, I'll give you some hormone pills. Your bleeding will stop. Nothing to worry. Go. Is that the right thing to do? No, because if you do that, you leave her. Can this endometrial hyperplasia 5 years down the line lead to endometrial cancer? And yes, please remember, this can lead to endometrial cancer type 1, and that is what I'm very bothered about. I am not worried about hyperplasia, वो तो ठीक है, bleeding ही तो हो रहा है ना, big deal. But I am worried that what if in the later run I don't treat it and she lands up with endometrial carcinoma, which is a type 1 cancer. That is what I will be very worried about. So I will have to immediately do a surgery. I will say, okay, ye nikalo, ovarian tumor, remove it. As soon as you remove the ovarian tumor, the estrogen levels will go down. The endometrium will automatically become fine, and then later on she will not have endometrial cancer. So now my question to you, give me yes or no. Endometrial hyperplasia is pre-neoplastic, pre-cancerous. Is it pre-cancerous? Can it cause cancer? Answer is yes. This was your female etiology. Now let's take one example of males, and in males I will talk about prostate hyperplasia. So now all of you will tell me a simple question. Endometrial hyperplasia is because of which hormone? Estrogen. Prostate hyperplasia is because of which hormone? It is due to which hormone, guys? Yes, batao. Perfect. It is due to, and this I will wait, although there is a 10-second lag in receiving comments at my end, but I will still wait. I will not give you the answer because everyone says that endometrial hyperplasia is because of estrogen. So, ma'am, prostate hyperplasia will be because of testosterone. What a dumb question. Sometimes when we think something is like we are too above it, ये तो बहुत simple वाला question है, but वहीं पे overconfidence kills the cat, because prostate hyperplasia is not because of testosterone. Now let me tell you, because exactly the same question came in the exam. Option A was testosterone, everyone ticked. Option B was DHT, and that is what I'll tell you. See, every male has testosterone, of course, and testosterone undergoes a metabolism, and that metabolism, the metabolic product that is formed is DHT, dihydrotestosterone. Dihydrotestosterone. Anyone who can tell me which is the enzyme that causes this conversion? It is 5-alpha reductase. Basic physiology and even pharma you study. Every male testosterone by an enzyme called 5-alpha reductase changes into DHT, and do you know it is not testosterone that causes hyperplasia? It is dihydrotestosterone which is going to cause the prostate to become big. That is going to be DHT. So that exam options were A, testosterone, B, DHT. What should have been the correct answer? DHT. But everyone in that overconfidence said, "Arey, testosterone hoga." This is one mistake which you will not make. Second mistake, everyone thinks now you tell me, endometrial hyperplasia causes endometrial cancer. So now tell me yes or no. Prostate hyperplasia, does it cause prostate cancer or does it not cause prostate cancer? Is prostate hyperplasia going to be pre-neoplastic or not? So this is not pre-malignant. Bilkul ulta chal raha hai. This, because otherwise, thank God, it is not pre-malignant. Why do I say that? Because I believe everyone knows that almost every man is going to have prostate hyperplasia after the age of 50. 50-55 के बाद almost every man has increase in prostate gland size. It is something physiological only nowadays. And if every man has it, and it would have been pre-cancerous, then every man would have died of prostate cancer. So thank God, prostate hyperplasia is not pre-malignant. It doesn't cause prostate cancer. So now all that I have to worry about is, okay, prostate hyperplasia cancer to nahi karayega. Chalo, I am happy about one thing. But prostate is very close to urethra. Man will have urinary complications. He will say, I always keep feeling that I have to go to the washroom. I keep feeling that I have not passed urine. Urgency hota hai mujhe. So he will have urinary complaints. So you will have to treat him for that at least. And what is the treatment? You will say simple. The cause was DHT. So remove DHT. To remove DHT, you remove this hormone. What is the treatment? 5-alpha reductase inhibitor. I will go and inhibit this enzyme. This is what you're going to study this year. It's your pharma second year. Name a drug which is 5-alpha reductase inhibitor, and the name of that drug is finasteride. So now you will study that, oh, this is the drug that I'm trying to inhibit, or this is the enzyme. If I inhibit it by giving finasteride, DHT will not form. Apne aap prostate hyperplasia will start getting fine. Perfectly done. So you are done with 2. See, your short notes are ready. If you get a short note on hypertrophy, first you write introduction, that is definition, increase in cell size. Second, you explain this entire mechanism. Next, you say that there are some examples which show both hypertrophy, hyperplasia, and then you mention that, okay, only hypertrophy is seen in bodybuilders and proximal to obstruction. If you get a short note on hyperplasia, it's an increase in cell number. Mechanism is that there is cell division. Common examples you already know. Finally, coming to the examples of hyperplasia only, one is going to be in women and one is going to be in men. But tell me one hyperplasia which you will get as an MCQ which can happen in anyone, any age from in utero fetus to till death, in men also, in women also, and in every other gender also. Okay, very good. Dr. Anmol has already mentioned erythroid hyperplasia, exactly what you shall be going ahead and doing now. It is going to be the third one, which is gender neutral. This can happen. What do you understand by erythroid hyperplasia? So hyperplasia, we know that the number is going to increase. Erythroid means red blood cells. So let me draw one bone marrow over here. Okay, let me draw one bone marrow, because that is where RBCs are formed. Now, these are all, I'll make red color cells, okay, RBCs. And after those RBCs are formed, they are sent into the peripheral blood. Okay, and they are, what is the total life of an RBC? Total life, which I'm not writing because you know this since NEET UG days. The lifespan of a red blood cell is 120 days. So ma'am, it is going to survive in my blood for 120 days. But what if someone has a disease? What if I'm talking about a disease that is known as hemolytic anemia? What do you mean by anemia? We know, ma'am, this though non-medicos also know. Anemia means the hemoglobin has gone down. Why has hemoglobin gone down? Hemolytic breakdown. There is going to be RBC and lytic means lysis or breakdown. RBCs are breaking. You had made such nice RBCs over here, ma'am, but now these RBCs are breaking. Whatever may be the reason, maybe it is because of some drug, maybe it is because of some genetic problem, RBCs are breaking. And then imagine your bone marrow will get so angry na, कि I did so much of effort, I made new things and I gave it out and someone is breaking them. What will your bone marrow do? Your bone marrow will become very furious. He'll say, never mind, I will make more. It's a revenge that, okay, if you are in need, I will help you. So what will your bone marrow start doing? Your bone marrow will now start making more and more and more of these cells. Can I say this is going to result in a compensatory mechanism? Compensation kaise hoga? There is going to be increase in the number of the, or I would not say number, but increase in the production. There is going to be an increase in the production of the red blood cells just as a compensation. Have we all understood? Very good. So Dr. Anish says that whenever I have to increase red blood cell, I always need one factor, and that is going to be by which factor? Erythropoietin. Erythropoietin, name only tells me erythropoietin, because erythro means RBC, that is going to go and increase the production of RBC. Is that okay with everyone? Dr. Anmol, I know many books also mention megaloblastic anemia, but when we will study in RBC chapter, you will see that in megaloblastic anemia, the bone marrow is also trying but is not successful. So I would not say megalo as a very first cause. Hemolytic anemia is a good cause, that okay, if someone is breaking my red blood cell, then my bone marrow will say, I will help you, I will make new red blood cells for you by using what? By using erythropoietin, so erythroid hyperplasia. Are we done with these two? Because now I can move on to the next adaptation. The next adaptation is atrophy. What all have you increased? What did you increase in hypertrophy? Ma'am, you increased the size of the cell. What did you increase in hyperplasia? Number of the cell. But what will you do in atrophy? Decrease both of them. You decrease the size of the cell and you decrease the number of the cell, and you are settled. And that is what we studied. This is what is atrophy. It is a decrease in the cell size as well as the cell number. It is decrease in the cell size as well as the cell number. And now you will ask me, so let me ask you, like abhi you did a bodybuilder. Your bodybuilder had gone to the gym, done deadlifts and squats and whatnot. He had done his bicep tricep curls and he has a good body now, but now unfortunately he had a fracture, and because of that he could not go to the gym for 6 weeks or 8 weeks. 2 months he was on bed rest, he did not go to the gym. What will happen to the size of his muscles? Will they remain the same, hypertrophied? No, they will start becoming smaller, and the day his plaster will be removed, you will see that his arm is looking very, very patla, it's looking very thin, because all the muscle is lost, atrophied. That is what is atrophy, decrease in cell size and decrease in cell number. So they will ask you, what is the mechanism? This decrease is going to be by the UPP pathway. UPP means it is the ubiquitin proteasome pathway. It is the ubiquitin proteasome pathway. This pathway is, you don't, firstly, thank your stars that you don't get a short note on ubiquitin proteasome pathway. So no one is going to ask you this. But just in case they ask you atrophy, they will ask you which is the mechanism. So this is something like very good, like you said, that there is going to be ubiquitin is a protein. Proteasome tells me that we are acting on the protein pathway. So like Dr. Anmol is saying that okay, the basic concept is that you are targeting the proteasome pathway. You are targeting the proteins. You are going to decrease the protein synthesis. You will not let the proteins form only. And the proteins which are already formed in the body, you will make them break. There is going to be increased protein degradation. So when you are doing everything for protein, ma'am, you're not letting new protein form, decrease synthesis, you are breaking the protein. So which pathway you must be using? You must be using the UPP, ubiquitin proteasome pathway. Let's understand this better with the help of some examples. I've got you some headings. Let's do some real-time, real-life examples with this. Number one, disuse atrophy. Like I said, guys, what is this? A symbol? ये क्या symbol होता है? Especially all the Gen Z people who are our social media enthusiasts, they will say, oh, this is a hashtag that is used on Instagram and Twitter. But in medical language, this is the symbol of a fracture. So whenever someone has a fracture, this is what is written in the prescription. This hashtag is there. So let's assume there is a fracture of, say, the right leg. just an assumption. Right leg mein there is a fracture, and what is done in a fracture, ma'am? Some POP cast is put up for roughly 6 to 8 weeks. That's the usual protocol. So cast was put up and the patient was said that you don't have to move your leg for 6 to 8 weeks. What do you think will happen to the muscle? There is going to be a decrease in the muscle. Basically, the muscle, see, what are the purpose? I'm going a little bit into orthopedics, but why do you put a POP cast? If this, for example, is a bone and the bone has broken, the purpose of putting a cast is that these two broken pieces, they should always remain joined. No, they should not, this shouldn't go in this direction and that direction. Then how will they meet? They should always remain joined. That is why you've told the patient that I've put a POP cast, don't move your leg for 6 weeks. So the bone will join in 6 weeks. Okay. But what happened to the muscle around this leg? The person did not move his muscle for 6 weeks. Disuse. He did not use an organ for 6 weeks. So of course there is going to be disuse atrophy very commonly. And then what is the usual protocol? After 6 weeks, what will you do? You will remove the POP cast. Bone jod chuka hai, fine. But then do you always tell the patient that do go for some physiotherapy sessions? Don't start running the day I remove your cast. Don't just go for a marathon. Gradually build up your strength, because gradually only you will be able to get your muscles back, because they have undergone atrophy. So physiotherapy is very important so that you can get the strength back. That is the example of anything you don't use for a very long time, atrophy will happen. Any muscle you don't use for a very long time, atrophy will happen. Next, if I don't, for example, give someone food for months and years, malnutrition, macro and micronutrients are not received, obviously the muscles and the organs will start shrinking. There is nothing to write in front of it. It is obvious. Macronutrients not received, micronutrients not received, the organs will start shrinking. Obvious. Blood supply is not received, ischemic atrophy. Nerve supply is not received, denervation atrophy. So let's do some examples for everything that I have made you write over here. Yes, starting with malnutrition. For example, cancer. Now you must have seen that cancer patients always become very, very thin, and obviously one problem is that they are receiving chemotherapy. Chemotherapy has a side effect that it makes the person very lean. But even without chemotherapy, you are right, there is something known as cancer cachexia. Basically, the person becomes very, very lean, very thin. And the reason being that the person A is either not eating well. One thing could be the reason of consumption. Second is that it is said that cancer tends to take away all the glucose. As I will teach you later on, cancer always is very hungry for glucose. It consumes all the glucose of your body. So the other organs are not receiving any glucose. That is why the patient is going into malnourishment. So obviously, how will the patient start looking? You've seen cancer patients, they start looking very thin. Second, ischemic atrophy. Ischemic atrophy basically means that if this is a blood vessel, there is a problem in the supply of the blood vessel. Ischemia, blood supply is not getting adequate, and this is what you see in old age. Senile atrophy in the brain. This has been noted in the brain, in the central nervous system, that you must have you will never get to see, because no one in old age takes his brain out. This is something you can only see if a patient dies at the age of 80, 85. You will see considerably the size of the brain is smaller. Shrinkage happens of the brain. That is because blood supply undergoes a problem in old age. So senile for old age, atrophy in the brain is because of what? Because blood supply is not going adequate. Similarly, nowadays, although it is not 100% established, but they are also saying that in Alzheimer's disease, have we all heard of Alzheimer's disease? Memory loss hota hai, people forget all their family members and their day-to-day activities. In Alzheimer's disease also, they are saying that the brain is nowadays, it is said that there's a problem in the blood supply. Okay, if I cut the nerves to an organ, you must have seen, although now polio is not very commonly noted, but you must have seen one or the other patient of polio. And in polio, you must have seen that one limb has a problem, so they are limping, because polio is a disease, it's a virus that goes and attacks the nerves. It has actually caused denervation. So maybe the nerves are not working. Then how will the right limb or the left limb walk? How will the patient walk? How will his limbs walk? That is why they are undergoing atrophy. Nerve supply ko problem kara, atrophy. Blood supply ka problem, atrophy. Food not receiving, atrophy. Coming to the last one, endometrial atrophy. Why do you think? Right now I taught you endometrial hyperplasia some time back. Why was endometrium becoming very thick? What was increasing? Estrogen was increasing. Now I'm saying Endometrium is becoming very thin. Ulta. What is it going to be due to, ma'am? Because estrogen has gone down. Common sense. I mean, nothing could be obvious than that. Yeah, very good. You're saying menopause. Naturally, when does a woman's estrogen go down? When she's reached her menopause stage. So every menopausal woman normally has endometrial atrophy. That is what we call as old woman, 50, 55 plus. Her endometrium has undergone atrophy. This is normal because she has decrease in estrogen. But now I want to ask you is, can this be cancerous? Can this lead to endometrial cancer? Yes, and this is known as endometrial carcinoma type 2. This is known as endometrial carcinoma type 2. So now I want to ask you something. For endometrium, I have made a small flashcard so that you don't get confused. Endometrium can either become very, very thick, that is known as endometrial hyperplasia, that is because of increase in estrogen. Or the endometrium can become very, very thin, that is atrophy because of decrease in estrogen. Simple, this is decrease in estrogen. So hyperplasia due to increase and atrophy due to decrease. Can both of them cause endometrial cancer? Yes. Increasing female genital tract is so complicated. Endometrium hyperplasia hua, then also cancer. Hyperplasia nahi hua, then also cancer, but the type of cancers are different. Hyperplasia causing cancer is type 1 endometrial cancer. Atrophy causing cancer is type 2 endometrial cancer. Now you think patient gives even 2 minutes of thought and is interested to know whether she has endometrial cancer type 1 or type 2. She'll say, hey doc, I have endometrial cancer. My world has anyway collapsed. I have been diagnosed with cancer. To hell with whether I have type 1 or type 2. I don't care. I have cancer. That's more than enough. But you are wanting to know that, no, I want to know whether she has type 1 or whether she has type 2. Why do you want to know? Because it is said that type 2 endometrial cancer for the patient is going to have a worse prognosis. So for the patient survival, this is something that you want to know. From the pathologist, you will ask that in your report, please write, look at the patient. First, she had hyperplasia following cancer or she had atrophy following cancer, because if she's in this situation, then her survival is even worse. It is going to have a worse prognosis. Is that okay with everyone? Can I move on to the last cellular adaptation and the topic for the day, that is going to be metaplasia? That's the last one. Okay, Dr. Anmol is saying pressure atrophy. Yeah, this is something I'm not teaching you here. Reason being that we have not studied female genital tract. But if you have asked me a question, I can't leave it unanswered. Then I shall have to teach you. Pressure atrophy is something which you see in, as I said, female genital tract. If you know about it, guys, then I will teach you here only. If I draw this as the uterus, do you all know a fibroid? Fibroid is nothing but a leiomyoma. Have you all heard of it? Leiomyoma and fibroid, have you guys heard of that? So what is it? Oma always means a benign tumor and myo means muscle, so smooth muscle. This is a benign tumor in the smooth muscle. Smooth muscle is what? Myometrium. If you're talking about the uterus, ma'am, then you are talking about myometrium. So if this was a leiomyoma, 2 centimeters, female would not have been bothered. But if this leiomyoma ends up being something like a 10 centimeter big tumor, ma'am, that is huge. For a tiny little uterus to have a 10 centimeter huge tumor, this tumor is going to create a lot of pressure. And what is this tumor going to create a pressure on? What is the internal lining? The internal lining is endometrium. This tumor will start creating a pressure on the endometrium. And can it cause pressure atrophy if it is very, very large? In case the fibroid is very, very large, it can cause something called pressure atrophy. TX, Dr. Tushar, TX is the short form we use for tumors. Okay, that is universally used in every subject for tumors. So like I'm saying, this is a smooth muscle, OMA. OMA means tumor, right? So TX is our universal mnemonic, or not mnemonic, it's a short form which all doctors use for tumors. Okay, so if this is a very big tumor, ma'am, of course, it will start putting pressure on the side and it will start putting a pressure on the endometrium. So it will cause pressure atrophy. Is everyone okay with this as well? But obviously this I will teach you better when we go to female genital system. When I teach you this leiomyoma, fibroid, tab better samajh aayega. Finally done. Moving on to the fourth and the last, that is metaplasia. Very interesting. And if you ask me, ma'am, what is the most likely chance of getting a question, it's always short note on metaplasia. So this is what you have to listen most importantly. Sabse pehle, metaplasia is the change. Just learn one word, change. Bas khatam. For your understanding, something is going to change in the body. Now let's do for your exam. Change of one tissue into another tissue. When one tissue changes into another tissue, what kind of an arrow have I drawn? ये exam में मत बना के आना. This is our understanding वाला arrow, because this will always help you learn the definition better. When one tissue changes into another tissue, and I have made a reversible wala, chemistry के equations का reversible wala arrow, yes, which means that if one tissue has changed into another tissue, after few days it can come back to its original form. That is what can happen in your body. Let me give you example. So I've written tissue. So you take the example, ma'am. Let's take the tissue to be one epithelium. I'll say, one epithelium, it can change into another epithelium. Not a problem. But whenever the situation will be fine, this change will become back. If not epithelium, it could be mesenchymal tissue. One mesenchymal tissue is going to change into another mesenchymal tissue. And when the situation will be fine, then the change will go back, means it's going to come back to normal. So now, can I say this is always reversible? Before I tell you, definition समझ में नहीं आता. Similar to the 3 Idiots story, that the movie 3 Idiots you must have seen ना, कि definition तो पढ़ लिया, but have you understood the essence of it, the meaning of it? Definition I've told you. One tissue changes into another tissue. That tissue could be epithelium changing to epithelium or mesenchymal changing to mesenchymal. Definition हो गया, which tells me it is always and always reversible. But ma'am, before you go to the definition ka details, tell us some examples. I will come back to this slide after teaching you 3 examples. The first is going to be the example of the lungs, because I believe smoking is something which is so prevalent that everyone will be able to relate to this in some form or the other. If you are a smoker, then you should be over vigilant right now, because after this, at least for few days, you might not want to smoke. So let's talk about the lungs. Can you all tell me, you just walked out of anatomy, histology, what is the normal epithelium of the lungs? The normal epithelium, which is written as pseudostratified ciliated columnar epithelium. Do you remember this term from first year? Even if you don't remember, at least remember the word cilia are present in the lung. Pseudostratified ciliated columnar epithelium. If I have to draw it, columnar, long cells, this was columnar epithelium, and it is going to have these cilia. But the problem is that people who smoke for a very long time, what does smoke do? Smoke damages these cilia. The cells are being damaged. So please remember, the smoke is now going to go and is going to damage the cilia, and then your body is like, what the hell is happening? I made cilia for protection so that this person would have been protected from all that dirty air pollution, AQI and everything, dust particles. That is why cilia was made, and this person has smoked so much that he has damaged his cilia. What will your body do? Will your body say, jao maro, go die? No, na. Your body always adapts. Your body will say, okay, never mind, he's a fool, he's smoking, but let me try and help him. I will make a new epithelium for him. He has damaged the previous one. Let me make a new epithelium for him. What is that epithelium now? The body makes a squamous epithelium. And now tell me, one epithelium has changed into another epithelium. Do you want to call it a metaplasia? Yes, I do. When one epithelium changes into another epithelium, but what so many students come to me and say, "तो ma'am, ये तो इतना ठीक है, this is fine, because you have taught us metaplasia is 100% reversible. So ठीक है, till the time I'm smoking, the epithelium will change. The days I'll not smoke, or when I'll stop smoking after 4-5 years, it will all come back to normal." And I'm like, yeah, that's right. That doesn't give you a cause that, oh, you can smoke and it's not a bad thing, because technically, yes, it is always reversible. Whatever has changed, it can go back. But the problem is that only till this stage it is reversible. What if you decide to quit smoking after 15 years? After 15 years, you said, okay, now from today onwards, I will not smoke. But for 15 years, you were smoking. Your epithelium has changed into squamous epithelium. And in those 15 years, this squamous epithelium has started showing you precancerous changes. it has started becoming squamous cell carcinoma. Squamous cell carcinoma. Now tell me, if cancer has started forming, now can you get back? If you leave smoking, will you be able to go back to the normal state? If that would have been the case, then the entire world would have been smoking and would have been all hale and hearty and happy. So that's not possible. Reversible is only till you are in the epithelium stage. The day precancerous stages start coming in, then it is no longer reversible. Now tell me, I am making an arrow here, but what is the name of this metaplasia? And that is where students make the maximum mistake. Options में होगा या when you will write your short note, you'll have to give a heading ना. तो इसको क्या metaplasia बोले? Should we call it ciliated metaplasia? Or should we call it squamous metaplasia? Ma'am, metaplasia का क्या नाम रखते हैं? This is the most common metaplasia. That is why I'm teaching you first. This is known as squamous metaplasia. What did you take home? Terminology कैसे होता है? How is the term set? Is it on the starting epithelium or is it on the ending epithelium? So you always say end result matters. The end result always matters. So I would say that the ending is what the name of the epithelium is decided on. अच्छा, end में क्या बना? End में squamous epithelium. So the name of the metaplasia is going to be squamous metaplasia. Okay with everyone? Now, if someone comes to me and says that, ma'am, I have never smoked in my life. ऐसा तो नहीं है ना that people who smoke only they land up with all of this. People who never smoked, and then I'll say, oh, maybe you had a very bad AQI. He says, no, I was living in the hills. My AQI, air quality index, was below 20, below 10. I've had the most healthy lifestyle. Still also I am seeing all this happening in my body. What could be the other concern? It could be vitamin A derangements. Derangement means it could either be a vitamin A deficiency or it could be a vitamin A excess also. Both the situations are possible. That vitamin A problem can also cause the same kind of metaplasia. So this is what you remember for first one example. I'm going to give you more examples, but before that, let me just quickly show you one photo. This photo you don't have to draw in your university exams, but you need to understand what happens in your lungs. Let me show you this, guys. This is your normal epithelium in the lungs. Can you all see these tiny hair coming out? What are these tiny hair? These are the cilia. This is how our normal, I'm going to scan through. I have zoomed in so that you can scan through the entire epithelium. You can see the entire cilia in one place. I can see it. Oh, this is the normal cilia. Thank God we have it. All the dust that goes, these cilia are going to put it out. But this person did not value what God gave him and he ended up smoking. Can you see what has happened going further in this? I'll go further from here. I'll keep highlighting. If you see a cilia, let me know because I can't. In this much area, I see that the cilia are totally gone. I don't see the cilia. Can you see it? I don't see any cilia. Then I can again see the cilia again from here. But in this area, what I can notice is that there are no cilia. God has started making another epithelium over here. And this is the squamous epithelium. So this is what happens in people who smoke. And that is how later on they can land up with cancers. Have we all understood it? Yes. Now can I move on to the second example, which is Barrett's esophagus. That is also a metaplasia. Before that, you will tell me, in esophagus, what is the normal epithelium? The normal epithelium is the squamous epithelium. First year anatomy histology file that you used to make, the normal epithelium is squamous epithelium. But now I have a patient of GERD. Anyone who knows what is GERD? It is gastroesophageal reflux disease. It is, and whatever you have written, you will draw with me. It is not that you are mugging up a disease, because surgery and medicine, you study this a lot. So I will teach you in pathology only. Gastroesophageal reflux disease. Ma'am, gastro means what is in the stomach? Of course, we know in the stomach there is a lot of acid. Gastroesophageal reflux. Now the acid is going to come back into the esophagus. Reflux will happen. See, stomach always has acid. Stomach ko to aadat hai. Stomach knows I will always have acid. Stomach never gets damaged. Esophagus is not used to, okay, acid will come. But if stomach say acid, if acid starts coming back into the esophagus is like, oh no, I am getting acidic, acid will burn me, and that is what happens. Acid comes back and acid starts burning the esophagus. What was the normal epithelium? Squamous epithelium, that is gone. Now God will give you something else. God will start making an epithelium which can fight the acid. That, oh, I have to give an epithelium which can fight the acid. So now God changes it into intestinal columnar epithelium. God changes it into intestinal columnar epithelium. So you're like, ma'am, squamous epithelium saw the acid and got damaged. Very scared. कि, oh, acid आ रहा है, damage. Intestinal columnar epithelium will be able to tolerate the acid. Yes. Why and how? What is so strong about intestinal columnar epithelium that it can, it can easily say that, oh, let the acid come, I'll manage. Because this epithelium has something known as goblet cells. Goblet cells. Firstly, goblet means a glass. Usually it is used a goblet of wine. You must have seen in many Hollywood movies also, fictional movies also, goblet. It was also there in Harry Potter. So goblet always means a glass. Exactly, cells which look like a glass. And if ma'am there's a glass will always be filled with something. So the cell that I will show you, it will be filled with something, and that is going to be acidic mucin. What has God put inside this glass? Acidic mucin. That is making sense. Now think logically. And yes, Dr. Anmol, why not gastric epithelium? Because although goblet cells can form over there and gastric epithelium has been seen in Barrett's esophagus, the commoner one formed is always intestinal, because the content of goblet cells are more. And if goblet cells are more, this means mucus production will be more. Why am I wanting mucus production? Because mucus can easily fight against acid. The main problem is that acid is coming back. Now, when acid is coming, I need someone who can fight with acid. Mucus can easily fight with acid. So that is why God made intestinal, columnar, gastric also. When you read basic histology, na, gastric stomach also has goblet cells, but the quantity of goblet cells are not much. Intestinal columnar epithelium has maximum goblet cells. Hence, we have made that it will have acidic mucin, and that mucin will easily fight. So God has given you a protection, right? God has given you protection. That was the heading of this topic, cellular adaptation. God is wanting you to adapt. Now, before I show you photos, all of you will tell me something. What should I name this? This entire disease is called Barrett's esophagus. It is a metaplasia. What should I name it? Should I call it squamous metaplasia or should I call it intestinal metaplasia? क्या बोलना चाहिए? Ma'am, you taught us that end result matters. End result is intestinal. So either you should call it intestinal metaplasia or you should call it columnar metaplasia. One of the two. You should use these two terms for the metaplasia. You should not be using anything else. Very good. All of you have got it. Now let's see the photos. Here you have. So first I will show you normal esophagus. This is the normal esophagus. What is the normal epithelium of the esophagus? Squamous epithelium. I will zoom in and show you all photos because abhi I consider you as babies and you will never ever understand photos in this chota sa picture. You will always have to zoom in. Look at just normal part. Just this is the normal epithelium. How do we always, how I used to identify in my second prof when you can't understand anything. Hamesha, squamous epithelium, you will see layers, you will see multiple, whether squamous epithelium is in the skin or squamous epithelium is in the oral cavity or the tongue or the esophagus, it is always going to be one cell on top of the other. And in that also, you will notice that as the I don't know how many of you remember this from first year, but if you've forgotten, then I'm reminding you, the cells at the bottom are still a little round. You can see the cells are coming round, but as you go to the surface, can you see they are starting to become like this, a little long and flat? They have started becoming flat like this. I will zoom in to the maximum that we can see. यहाँ पर जो cells हैं, they are all coming out to be round. But as I am going up, I can see the cells are trying to become flat like this. That is how I identify squamous epithelium. So सबसे पहले, could you all notice the squamous epithelium? Normal, okay. But then next to that, I will draw the demarcation. Next to that, suddenly I saw there is no squamous epithelium. There is some epithelium in which there are, ma'am, these glasses made. Can we all see those khali cells? The goblets, the glasses, such beautiful goblet cells made. Okay, these are all the goblet cells and they are filled with some light blue material. That must be the mucin. So I can finally see, if you see goblet cells in the esophagus or kuch banana hi nahi, it is Barrett's esophagus. Let me show you one more photo of goblets. This is also a very nice picture. You can see those khali, empty glasses. Oh, this is the goblet cell. They must be filled with acidic mucin. So if you say that, ma'am, How can you confirm for pathology? You sit in a rainbow, you have a lot of colors. So for acidic mucin, is there a special stain that you have? And the name of acidic mucin special stain is going to be Alcian blue. The special stain is going to be Alcian blue. It is Alcian blue positive. Repeating, acidic mucin is Alcian blue positive. That is the special stain. Is that okay with everyone? Yes. Shall I show you one picture? Before I show you, let me see how much you started understanding pathology. Acidic mucin is positive for Alcian blue. What must be the color of the slide? Common sense. This is how. See, abhi tak goblet cells were looking, ma'am, whitish, khali, khali. Suddenly, the goblet cells are now looking blue. What stain have I put over here? Over here, ma'am, you must have put Alcian blue stain. Because of that, the goblet cells have started looking blue, blue, blue now. Now I'll say, yeah, they are blue because they have acidic mucin. Can I come back? Because now I want to ask you, full Barrett's esophagus is done. So when you will go to your Q bank also, you will find what is the hallmark. You will find goblet, goblet, goblet word written everywhere. My next question is, if you don't stop, your first thing is patient will say, Arey, apna to story you carry on, but my problem is I'm having acidity. I mean, my acid is coming back again and again. I'm feeling like a burning sensation in my chest. I feel sometimes I'm having something like a heart attack because my chest is burning all the time. So you will give him antacids. You will do your treatment. If you don't do the treatment, then what? Acidity ही तो है. If you say अरे acidity ही तो है, keep having antacids whenever you have and keep going on. You will have Barrett's esophagus forever. What is the risk? This is then going to be pre-malignant. Can Barrett's esophagus later on cause cancer of the esophagus? Yes, pre-malignant. And they will ask you, which cancer of the esophagus does it cause? It causes adenocarcinoma of the esophagus. It causes adenocarcinoma of the esophagus. And now I realized that even in the lungs, ma'am, you were telling me that in the lungs also when metaplasia was occurring, you were saying, oh, it can cause cancer. Now in Barrett's esophagus also you are saying that, oh, once metaplasia will occur, then it can cause cancer. So this means if they ever put a statement, is metaplasia pre-malignant? Yes, and I can add that to my definition. Number one, it is always reversible. Okay, but can it be pre-malignant? Yes, it can be pre-malignant. See, I told you I'll keep coming back to the slide. So what did I study? Metaplasia is one tissue changing into another, like one epithelium to another. I've told you examples, but I've only told you example epithelium to epithelium. Like in the lungs, it was ciliated epithelium to squamous epithelium. In Barrett's esophagus, it was squamous epithelium to columnar epithelium. The other situation I have not taught you. Even mesenchymal tissue can change to mesenchymal tissue. तो होता क्या है? What is mesenchymal tissue, guys? Everything other than epithelium. Epithelium पढ़ लिया, but everything other than epithelium. Fat, bone, cartilage, muscle. This is all mesenchymal tissue. So give me an example of mesenchymal metaplasia. An example of mesenchymal metaplasia is going to be myositis ossificans. If you are a smart one, you will know what is changing to what. It is so obvious. You will say myo means muscle. Myo means muscle, and ossificans, ossification, something like a bone. So either something to do with calcium or something to do with bone is what is written. Simple. Yes, that is what it is. Myositis ossificans is when muscle changes to bone. ऐसा कैसे हो सकता है, ma'am? How can muscle change to bone? I will give you an example. This is usually due to some kind of severe trauma. And listen to me very carefully. I mean, no one has written this anywhere in the textbook, so you will have to listen to it as a patient. If there's a person who comes to you, this is your patient, okay, and he says that I had a road traffic accident, and because of that, he was on a bike, he had a bike accident, he went, his bike skid, and he went on the ground, very, very bad, severe injury he's had on one leg. Let's assume on his, on his left leg, thigh, he has had an injury. So that time you will see all his skin is abraded, he's bleeding, you will do suturing or whatever dressing is required, you will send him back home, you will give him some painkillers and you'll be like, you'll be fine. 3 weeks later, he comes back to you. He said, okay, my wound and my skin and my bleeding and everything is fine. But in my thigh, I have started to feel something very hard. My thigh always has muscle. Muscle is a little firm, little softer, but I am feeling something very, very hard. So you get an X-ray done. On X-ray, you are seeing that inside his muscle, if this is his muscle, you are seeing there are some spots of calcification and bone formation that has started. Why? Because of that trauma, this change happened in the body. The body always said that I have to make muscle, but after that trauma, see, trauma changes everyone. Like we say, trauma changes us also. Same way, trauma said once trauma happened, the muscle also forgot that it had to make muscle. It started making bone over here. And for these patients, if you ask me that, ma'am, this seems pretty interesting, because a patient would come to me, तो इसका treatment कैसा होता है? So we actually go in for a massage. All that we can do, we can't just take the entire muscle out na surgery करके. You can just gradually start massaging the area, physiotherapy, massaging, so that whatever is forming can actually stop forming over there. So if they ask you the example of mesenchymal metaplasia, myositis ossificans, and if you get a short note, you're writing all. But the story is not over. Now you must be asking me, is there one organ that can show everything? And that organ is breast. Before I come to that, there is one part of the definition that still remains missing. Ye changing to pad liya ma'am, but changing why and how? What is the mechanism of metaplasia? I will write it and then you will be very worried. It is the reprogramming of the stem cells. It is the reprogramming of stem cells. So first you have to tell me, do you understand what are stem cells? Stem cells are the cells which can make everything. Like, for example, for your body, every organ has one stem cell. Have you heard that you can donate liver? Even when you are alive, a part of your liver you can donate. Why can you donate? Because your liver has stem cells. When you will donate little few grams of your liver, these stem cells will make the liver again. So stem cells have been designed that, okay, when you were being born, when you were in your mother's uterus, the God decided that acha, ye wale stem cells, they will always stay in the brain. Whenever brain tissue has to be made, these stem cells will make. The next stem cells, they will always stay in the liver. So every organ has a pool of stem cells. For your skin, like if you lose skin, your skin grows back. Why? Because God has given you stem cells in the skin. So every organ has stem cells, and they were taught, your work is you will only make skin. Next stem cell was said, your work is you will only make liver. Third one was taught, you will only make brain. Fourth was taught, you will only make muscle. But then, if by chance they decide that we will take some new coaching classes, like we say, don't change your source. Stem cell ne source change kar diya. Stem cell was always taught you have to make muscle. But one day the stem cell had a reprogramming, new tuition classes, new coaching classes, new online apps, new notes. And then the next day that stem cell said, no, now I'm not going to make muscle. From today I will make bone. And that is what is reprogramming. So basically, whenever there is any kind of severe trauma in the body, like smoking ho gaya, or there is an acid reflux in the body, or there is some kind of a severe trauma, these stem cells have a reprogramming. Unka coding change ho jata hai. Like in computer software you do coding, their coding changes. So till yesterday they were taught that you have to make muscle, but after the trauma their coding changed, their programming changed, and now they have started making bone. That is it. This is known as reprogramming of the stem cells, which is very important. So now before I proceed forward, what you will tell me is, can you give me a summary of all the mechanisms? This I have already written. You will answer jaldi. What are the mechanisms for all the 4 adaptations that I taught you? Number 1, you will tell me what is the mechanism for hypertrophy. If you remember, it was what? It was increase in transcription factors. Can you name the transcription factors for me? They were GATA4, it was NFAT, and it was MEF2. Okay, that was transcription factors. What are the things for hyperplasia? Ma'am, number to division se increase hoga, matlab by mitosis. What is the mechanism of atrophy? Atrophy was everything was going down. Protein degradation was occurring by the proteasome pathway. It was happening. And right now I told you what is the mechanism for metaplasia. Metaplasia is going to be, yes, that is going to be the reprogramming of stem cells. Before I end the topic, give me one organ which can show you everything. In the breast, do you know, you can see every kind of adaptation, and that's very interesting. Before that, I've got a question. Confused in metaplasia of cervix. वो तो अभी confusion होगा, because see, all female genital tract things like leiomyoma, cervix, I have not covered today. Since you've asked me, I will give you a very quick overview. What happens, Dr. Anmol? I'll draw that cervix again, okay? When we, abhi I'm not focusing on uterus. This is the cervix, okay? In the cervix, there are two parts. The one on the outside, this is known as ectocervix, not just for Dr. Anmol, this is for everyone because you have to eventually study it with me. And what you have on the inside is going to be endocervix, okay? And now just imagine, first tell me your basic anatomy. What is the epithelium? Ectocervix has squamous epithelium and endocervix is going to have columnar epithelium. I am telling you about normal epithelium of the body. Ectocervix has squamous epithelium, inside wala cervix that is going to have columnar epithelium. However, if there is some damage, now which damage am I talking about? That damage could be maybe the female is having some infection. These days human papilloma virus infection is so common, HPV in the cervix, or maybe the woman is having some unsafe sexual practices, or maybe she is undergoing some treatment, maybe some radiotherapy for some other cancer. Maybe she has a cancer here, she's undergoing radiotherapy for that, but radiation will hit everywhere, right? So maybe she's undergoing some radiotherapy or some chemotherapy, or in general she has some ulcers because of poor hygiene. Whatever may be the reason, you will see that this columnar epithelium will now start making more of squamous epithelium, or in other words, you will see the squamous epithelium has started covering. Like this, it has started covering the endocervix. So can I say the columnar epithelium will start changing into squamous epithelium? So Dr. Anmol, please tell me, what metaplasia would you want to call it? Columnar epithelium is changing to squamous epithelium. End result is what? Squamous epithelium. So can I say there will be squamous metaplasia of the cervix that will happen? And you yourself have told me, yes, prolapse, whatever. Prolapse is what? Basically the uterus will come down. This area will get exposed. It will get exposed means to the external surface there are ulcers, erosions, inflammation, whatever may be the reason of trauma. That is separate. The end result is same. Columnar will change to squamous. You will call it squamous metaplasia. That's the basic concept behind it. Now coming back, which is that one organ which can show everything? You will tell me. It's not me who's going to write it. Does breast show hyperplasia and hypertrophy during which stage, guys? During puberty and during pregnancy. Did I teach you? Yes, breast development shows you both. It shows you hypertrophy plus hyperplasia. But if you had to select one best, then during puberty and pregnancy, what does it show you more? It shows you more of hyperplasia. Do we know this already? Okay. What do you think will happen in after menopause? Post-menopausal or very, very old age, what happens in the breast? So obviously, ma'am, in the breast, there is shrinking of the size, or there is sagging of the breasts, means there is atrophy. Common sense. यहाँ तक तो पता था. जो question आएगा, when does metaplasia in the breast occur? This you don't know in second year. Why? Because surgery नहीं पढ़ा. So I will fill that gap. What is in surgery? In surgery, you study a disease called SMOLD. पहले नाम पढ़ लो. SMOLD stands for squamous metaplasia. Oh, squamous metaplasia. This means squamous metaplasia is what? Going to be what is formed? Starting squamous epithelium or later on? Later on squamous epithelium will form. What was in the starting? That is of the lactiferous ducts. Squamous metaplasia of the lactiferous ducts. So now what we'll do? We will draw. Now we will draw the breast. So we have drawn a breast tissue over here. This is the breast tissue that we have drawn. This is going to be the sorry, I think this, yeah, now it's working. This is the breast tissue that we have drawn. This is the nipple areola complex. And obviously from the nipple areola complex, this must be, ma'am, lactiferous duct is obviously close to the nipple through which the milk comes out. So this is going to be the lactiferous ducts. Normally, lactiferous ducts are lined by cuboidal epithelium. Normally, lactiferous ducts are lined by cuboidal epithelium. But that cuboidal epithelium will change into what? It will change into squamous epithelium. So over here, all that squamous epithelium is going to form. पर ऐसा क्यों हुआ, ma'am? Why did this happen in the female? This is due to smoking. Whenever a female is a chronic smoker, everyone thinks smoking मतलब या तो oral cavity cancer होगा, या फिर smoking means there's going to be lung cancer or there's going to be respiratory problems only. But smoke has impact on every organ of the body. So smoking is something that can change the epithelium of the breast. The cuboidal epithelium of the lactiferous ducts will change into squamous epithelium. That is known as squamous metaplasia. And this has been given a very, very fancy name that is known as Zuska disease. disease. This has been named as the Zuska disease. So what is Zuska disease? They will write Zuska, or they will write, I will label it, they will write it as SMOLD, squamous metaplasia of lactiferous duct. क्यों होता है? Smoking. So what is going to be the treatment? In the long run, you can not do anything but to help her leave her smoking habit. Once she leaves her smoking habit, you will see metaplasia is 100% reversible, ma'am. If she leaves her smoking habit, gradually things will get back to normal. Are we okay with this? This, by the way, is not written in Robbins. So the reason that I'm telling you is क्योंकि surgery से integrate होता है, तभी it's not written right now. But this will help you in your overall knowledge also. So breast is an organ which can show you all. Are we okay with this? We have done the summary. Before I end today's class, you have to answer 2-3 quick questions. After that, we'll quickly wrap up the class. All are true about metaplasia except 2 short questions, 1 long question. All are true about metaplasia except slow growth, धीरे धीरे, okay, reversible with treatment, irreversible, can be precancerous. All are true except, ma'am, irreversible तो कभी नहीं होता. It is, you have written, it is always reversible. Can it be precancerous? Yes, I taught you Barrett's esophagus can cause cancer, lungs में cancer हो सकता है. This is correct. Let's move on to the next question. Histopathological difference between Barrett's esophagus and the stomach mucosa. Now think, don't read this. खुद मुझे बताओ Barrett's में क्या था? Think of your answer and search for your answer. Ma'am, in Barrett's esophagus, you said you will see lots and lots of goblet cells. And goblet cells will have which kind of mucin? They will have acidic mucin. Acidic mucin will be positive for what? It will be positive for Alcian blue. This is what you taught us, ma'am. ये हम ढूंढ लेते हैं. Barrett's mucosa is acidic. Yes, acidic mucin. And Alcian blue positive. हाँ, ये तो मुझे ठीक लग रहा है. I think this is the correct statement. When I read other things, it is neutral, it is alkaline. ये गलत. Prussian blue, something random written. Gastric mucosa stains alkaline, positive. नहीं, gastric की तो बात ही नहीं हो रही. We are talking about Barrett's esophagus. Barrett's is Alcian blue negative, again no. So I thought of my answer. It has acidic mucin, मिल गया. It is Alcian blue positive, मिल गया. That becomes my answer. Rest statements are all random statements. Last question, which I told you will be lengthy. So it's a clinical question, patient oriented. Let us study. Okay, now we come to, before that, remains slow growth of metaplasia. Do tell me, Dr. Om, this was something जो पढ़ना नहीं है. This is something, sometimes you will get options which will be that you have to think, common sense लगाना है. You tell me, if someone starts smoking today, like today after this class, although I have scared you a lot, but still someone takes this as an inspiration and starts smoking today only after this class, will he land up with metaplasia tomorrow morning? Is it going to be a very quick phenomena? Or if he or she continues to smoke daily at a certain frequency, at a certain timeline number, and that will gradually, ma'am, the epithelium will change. If one cigarette would have caused, then in Delhi's air, we are today, North India, we are smoking equivalent to 30 cigarettes per day. That doesn't mean that in one day our epithelium will change and metaplasia will occur, है ना? So metaplasia is a slow process. It doesn't happen overnight. It doesn't happen within seconds. That's it. Coming to the last question that we have, the lengthy one. 47-year-old man who visits the outpatient clinic with complaints of heartburn and chest pain. What diagnosis? अब इसको ना clinically देखो. Not as के बस answer ढूंढना है. You have to think of heartburn and chest pain. Do you think this is acidity? Maybe this is gastroesophageal reflux disease. The pain is retrosternal. Initially it was with intake of solid foods. Now it's with liquid also, and now antacids are also not helping. So disease is becoming severe. In 6 months he's having major problems. He is worried about the pain getting worse with time. Yes, I can see that. He has also had weight loss, obviously because of all the chest pain. Physical examination, abdominal examination normal, no liver, spleen, कुछ बढ़ावा नहीं है. Hemoglobin is 10. Anything less than 12 is anemia. Obviously, he's not able to eat food properly. If he's not able to eat food, he's having weight loss, he's having anemia. Platelet count is 1, when they write 168 into 10 to the power 9, they are telling you in lakhs. So platelet count is 1,68,000. Do you know what is the normal platelet count? Above what? Our platelet count should be above 1.5 lakh. Above 1.5 is normal. So this person's platelet count is normal. ठीक है. Esophagogastroduodenoscopy. They've done an endoscopy. They are trying to see the esophagus, stomach and duodenum. They found an exophytic mass in the lower third of the esophagus. What is the most likely diagnosis? मैम हमने esophagus का चैप्टर ही नहीं पढ़ा, but you can put your common sense. Patient is having GERD. You tell me if this is my patient and he is having reflux, तो यहाँ पे क्या बना होगा मैम? यहाँ पे Barrett's esophagus बना होगा. And Barrett's esophagus can further on cause which cancer in the esophagus? I taught you Barrett's esophagus can cause adenocarcinoma, and that is what they've written. There's a mass in the lower third of the esophagus, obviously, because Barrett's esophagus occurs in the lower part, and then adenocarcinoma will also occur over there, and that of course is the answer to this question. So we are so we are done with this, and we are done with today's class. As I told you, we had to complete our cell deaths, all done, MCQs done, short notes done, cellular adaptations, MCQs, short notes done. Now after this, we are only left for the third topic to be some short notes in the next class. They are going to be intracellular accumulations, autophagy, free radicals, aging. ये सब बचा है. These are all अलग अलग MCQs and short notes. No long question left. For this entire chapter, your main long question was apoptosis, जो आपने already ये दो classes में कर लिया. Rest everything else is going to be short notes. Obviously, because next class will be the last class of this chapter, I will now start giving you more tips. Every class we will now, once we'll be done with this, I want all of you to do little homework. That is, you have to prepare a list of previous year questions of your university and college. That I can't do for you. I can tell you general that okay, pan India, apoptosis is a long question everywhere. Autophagy nowadays is short note. Cellular aging, they love to ask you questions on aging. But there will be one or two questions which will only be your university, your medical college specific. And if ever I miss out on anything which you feel that ma'am, theek hai, only in my college this is being asked, can you tell me one class prior so that I can include that also? You don't have to, you don't have to do that extra effort of seeing from Google or from Robbins that how will I write this short note. So that homework you will have to do every time. That, whenever I start a new chapter, do find from your seniors, get a list of all the previous year papers and find topics of that chapter, so that if I don't teach anything, maybe there is something which is not there in any college and only in your college it is being asked, then at least we can prepare that and I can get it for you in the next class. So that little bit of feedback has to keep coming from your end. Okay. Before we end, there were doubts which Dr. Om also had, and I think Dr. Anmol has also put up. So we are now taking up doubts. Okay, so I'm glad, Dr. Anmol, that right. Okay, so this is not a doubt. This is more of gratitude message. So thank you so much, and all the best for your exams in January. But I'm sure that we will not be able to, of course, get anywhere close to completing because this is a new batch starting. But if you followed through second year, I'm very glad and happy. This year has been very fulfilling for me also, Dr. Anmol, as an educator, because when you were in your second year is exactly when I started teaching. So, I mean, just prior to your batch. So that was the batch, the first batch that I started teaching as an educator, and that batch gave NEET PG this time in August. So I have also, I feel from second year subjects to NEET PG, I have completed one cycle of life. And now with you telling me that you are in your second year, you've been following and now you are giving your exams, I feel I've gone all the way back to that time. And I have gone into that loop where now you have started, you are going to give your exams, you will now enter into that NEET PG rat race. So I just feel that like one cycle I completed, now there's another cycle of live classes that we are going on to. But I wish you all the best, and I can see from your answers that you are going to do very well. So just keep up. I know it's a very bad time to have exams with New Year and very tough to study in winters, but if you put in that effort, then obviously the last lap is always the most important. So do your best, give it your best, and of course rest is destiny, but give it all that you've got. Yes, there were any other doubts from Dr. Om or anyone else? Should we wrap up the session? Do we have any doubts? Yeah, settled here. Okay, so thank you guys, thank you. Oh, okay, Dr. Parjesh, if you want offline videos, then you might find me very slow because right now I'm on 1x, and otherwise you guys are used to watching me on 2x. But this is the human version of me, that is the technical AI version of me, you can say, where I'm on 2x. But here I am on 1x, yeah. Okay, so can columnar metaplasia occur in the cervix? Yes, it can. Yes, Dr. Anmol, the other way is also possible. Squamous epithelium of ectocervix can change into columnar epithelium. Also rare hai, but ho sakta hai, possible. Okay, Zenker's degeneration, Dr. Om. Yes, this we studied in the last class. See, when you talk about Zenker's degeneration, although the name doesn't have it, but it's a type of a necrosis. कौन से type का necrosis है? Coagulative necrosis है. तो कहाँ होता है? What is the concept of it? The concept is, just imagine there is a patient who's had typhoid. You've heard of typhoid, na, Dr. Om? It is a disease where bacterial infection hai because of all the street food, golgappas and all that we have, na, that dirty water, dirty food, we end up getting typhoid. We have a lot of vomitings, food poisoning, diarrhea. वैसा वाला disease है मैम. Typhoid is simple food poisoning. But I am not teaching you typhoid. I am teaching you that in typhoid, complication क्या हो सकता है? There can be Zenker's degeneration, which means that in typhoid, in later after 2, 3, 4 weeks, there can be necrosis of the skeletal muscle. That is a complication of typhoid. Every person is not going to have it. Every person has typical food poisoning, diarrhea, vomiting, food poisoning. Very few people can have a complication where there is death in the skeletal muscles. And which two skeletal muscles? Obviously it's food related, na, abdomen related. So abdomen के muscles में होगा. One is rectus abdominis, the other one is going to be diaphragmatic muscle. So these muscles can start getting damaged. That is what is known as Zenker's degeneration. So every patient of typhoid is not going to have Zenker's degeneration. There are some people who have complication called Zenker's degeneration, where the skeletal muscle starts dying. Which skeletal muscle? Abdomen ka skeletal muscle, like rectus abdominis and diaphragmatic muscle. Okay, fine. Thank you so much for joining.